All good? I'm fine.
All good, sir.
So we are going live.
Yeah. Yes. So can we start?
Yes.
Yes, ma'am, please.
Yeah. So good evening, everybody. On behalf of Team Iage, me, Dr. Malaraj, the convener of this meeting, would like to welcome you all for this important meeting that is on complications in laparoscopy. So the anatomy of the human being has not changed so far, but then the technology and the operating techniques have been constantly evolving, where every gynecological pathology can be done laparoscopically these days, and as a result, there are some associated complications with these particular procedures. But then the key is that every early identifications and management is mandatory for a good outcome from this complication, which are generally encountered during the procedure. So the visionary of this particular focused webinar is our president, Dr. Pandit Palaskar, sir. And today, now we have Dr. Pandit Palaskar to address and welcome the gathering. Over to you, Dr. Pandit Palaskar, sir.
Hi, good evening, everybody. First of all, we are very thankful to Dr. Malaraj and Dr. Kalyan for taking this initiative. And she has done very well the compilation of the program, the selection of the topics, and stalwart faculties she has invited. So I think at the end of this webinar, we'll have the tremendous knowledge how to manage the complications, how to detect them, and last, how we can prevent these complications. Friends, laparoscopy is a interplay of so many things. We need to have proper selection of patients, proper selection of the equipment. Then we require special positioning, the stirrups, we require special anesthesia and intraoperative monitoring and special postoperative monitoring to detect and treat the complications. Friends, any surgery, whether it is open surgery or endoscopic surgery, complication is not a mistake. It is a part of surgery. It can happen due to the complexity of the case, due to inherent problems associated with that surgery, and sometimes due to the equipment failure or some there is a failure of equipment, non-availability of the equipment, and that sequelae can happen. So these complications, they should not be taken as moral disregard. It should be taken in positive way. I think in life there is no failure. From any situation, we achieve success, or if that success, the desired goal is not achieved, we learn we learn a lot of things from that situation. So don't take complications as failure of your surgery. You can learn so many things from managing that problem in positive way. So, friends, I think today we have very stalwart, good faculties, and definitely we should learn from them how wisely they have detected and managed that complication effectively. It is said that you will not have, you should learn from the complications of the others, because we don't have that much long professional career to do the mistake, to do the complication and learn from our own mistakes. So wise people, they learn from the mistakes of the others and take preventive steps to manage their patients in day-to-day life. So I think this is a very good opportunity for all the participants, the endoscopic surgeons who have logged in, and it will be very useful in our day-to-day practice. Again, I congratulate Dr. Malaraj and Kalyan for a very effective organization of this webinar, and we are very thankful all these faculties for taking out time from your busy schedule for our IAG members. And I wish you a great learning from this webinar. Thank you so much.
Yeah. So thank you so much, sir. In fact, it is quite inspiring to hear from you. Of course, complications do occur, and how we are going to manage is what matters. So to get the ball rolling, we start by taking the divine blessing. We light the lamp of knowledge and eliminate the darkness of ignorance. And to start with, we have the first speaker for the day, and that is going to be the very important topic, which is the anesthesia complication, what every gynecologist should know. The chairperson for this particular topic is going to be Dr. Ashwini Kalyankar, who is a very young, dynamic endoscopic surgeon from Mumbai. And she is the Youth Council member of Mumbai Obstetrics and Gynecological Society, and also faculty of Eagle Project. And she also is a committee member of the Foxy Endoscopy Committee. So may I request Dr. Ashwini to introduce Dr. Niranjan for the first talk.
Yeah, thank you so much, madam, for such a wonderful and this initiative. First of all, I would like to thank Iage, Dr. Pandit sir, Dr. Kalyan sir, and Beauty with Brains, Dr. Malaraj madam. Thank you for inviting me as a chairperson. So this is very important topic, I guess, but most neglected topic as far as the gynec laparoscopic side is concerned. That is the anesthesia and anesthesia-related complications in gynec laparoscopy. Maybe what kind of anesthesia, ranging from general anesthesia to the regional anesthesia, and pre-anesthetic workup, the changes during the laparoscopic surgeries because of maybe the CO2 insufflation, and many more things. So let's discuss. I would like to invite on digital dais Dr. A. Niranjan Kumar. He is the professor of anesthesiology at Stanley Medical College. He is having teaching experience more than 19 years, many paper publications, and area of interest are obstetric anesthesia and regional anesthesia. Over to you, sir.
Thank you, ma'am, for your kind words.
Mala ma'am, you need to stop your
Yeah,
screen
yeah,
share.
yes. Done.
Okay. A very good evening to one and all. At the outset, I'd like to thank Dr. Malaraj Madam, the convener, for giving me this opportunity, and all the other organizing team of Iage for this wonderful opportunity. As an anesthetist, I'd like to say that the complications we face inside the operation room, most of them are acute and need immediate and focused intervention. But the best person to help us inside the operation room is the surgeon, because he or she will be the most qualified and skilled person available to help us in the anesthesia room. So therefore, it makes a lot of sense and relevance to talk about anesthetic implications faced by the anesthetist in laparoscopic surgeries to all the gynecologists. Thank you so much. So I get into the topic right away. Everything starts with the basics. It is choosing the patient, preparing the patient, optimizing the patient, starting with proper history taking, documentation, investigations, and whatnot. And there are a few contraindications I would point out. They are heart diseases like right to left shunt, patient with extreme hemodynamic instability, patient in shock, patient with raised intracranial tension, retinal detachment, etc. There are also some relative contraindications. A patient with congestive heart failure, a patient with compromised cardiopulmonary status like emphysema, COPD, a patient with coronary artery disease or a history of MI, a patient with ventricular peritoneal shunt coming for laparoscopic surgery. These are all some relative contraindications. And the next step will be documentation, proper documentation of whatever we do, right from the investigations to consent and the checklists. Filling of all the checklists has proven to be a method to avoid complications. So with this, the next step is to choose the plan of anesthesia, whether it is GA or regional. So in most institutions, GA with endotracheal intubation and postoperative ventilation will be the choice of anesthesia. It has so many advantages. You can have better control over ventilation and better control over the hemodynamics of the patient. And the risk of aspiration of gastric contents into the lungs is minimized. Regional anesthesia is also used in laparoscopic surgeries. It is not a contraindication. There are many centers which use regional anesthesia. It has some advantages like the early recovery of the patient, better post-op pain relief. You don't have sore throat, things like sore throat and reduced rate of post-operative nausea and vomiting after surgery. But the downside is that in regional anesthesia, with all the raised intra-abdominal pressure and Trendelenburg position, the patient is awake and the patient needs to be very motivated and cooperative during the surgery. That is a challenge, and the patient can occasionally have shoulder tip pain due to diaphragmatic irritation. It is very difficult to treat it when intraoperatively with a lot of opioids. And as we will discuss in the subsequent slides, the raised intra-abdominal pressure and carbon dioxide absorption will require the patient to have increases minute ventilation by up to 20 to 30%, which is very difficult. It will be a increased work of breathing, which will be very uncomfortable for the patient. But still, short procedures like laparoscopic tubal sterilization all can be done comfortably with regional anesthesia. When it comes to choosing between endotracheal tube intubation or LMA, again, endotracheal tube intubation will be the choice in most institutions, but LMA can also be used, especially second generation LMA called ProSeal LMA can be used. It provides a seal up to 30 centimeters of water, which prevents, which protects the lungs. Next thing is whether or not to go for nasogastric tube. A well-prepared patient with nil per oral status for 6 hours for solid foods and 2 hours for clear fluids. When she is presenting for a gynecological procedure, which is a lower abdominal procedure, NG tube is not mandatory. But in special cases, like in an acute case where we do not know the nil per oral status, or in a patient with history of gastroesophageal reflux disease, putting in an NG tube makes sense. So what are the monitors we are going to use? Monitors, routine monitors, NABP, ECG, pulse oximetry, and end-tidal carbon dioxide, which is mandatory. We also add airway pressure monitoring. These are all mandatory in normal patients in whom we don't expect any complication. In already compromised patient, we need additional monitors. So again, one other thing we should know is whether we can go for medical grade air or nitrous oxide. There's a theoretical possibility of nitrous oxide diffusing into the intestinal gases and causing its combustion. And also, there's also a possibility of carbon dioxide air the size to increase because of diffusion. From the surgical point of view, diffusion of nitrous oxide into the bowel can cause its distension, especially in prolonged surgeries, which can interfere with the surgical field. So what do the case studies say? The case studies, many of them support the use of medical grade air instead of nitrous oxide. There are other case studies. There are case studies which again say that there is not much of an advantage with medical grade air. Both medical grade air and nitrous oxide can be used. So my personal preference is always medical grade air. Not for the reasons listed here, but nitrous oxide is an environmental pollutant. For that reason alone, we can avoid using nitrous oxide. So what makes the difference between open surgery and laparoscopic surgery? The three major factors, it is carbon dioxide insufflation, increased intra-abdominal pressure, and patient positioning. So we use carbon dioxide because it is not combustible, it is readily absorbed but immediately dissolved and excreted, metabolized and excreted. So like compared to other gases which have been tried, oxygen, air, nitrogen, this is far safer. So carbon dioxide is the gas of choice for insufflation to create pneumoperitoneum. So these three major factors, each alone and in conjunction with each other, cause profound changes in the physiology and therefore can lead to potential problems. So let's go into the altered physiological changes one by one. So first to start with ventilation and respiration. So effects of raised intra-abdominal pressure. So the ideal intra-abdominal pressure should be between 12 to 15 millimeters of mercury. So due to this increased intra-abdominal pressure, the movement of the diaphragm is impeded, and the functional residual capacity, the total lung volume are all decreased. The compliance is also decreased, and therefore the airway pressure is raised. This can lead to atelectasis during the intraoperative period and postoperative period. So next comes the increase in partial pressure of carbon dioxide. What it does to the ventilation and respiration. Carbon dioxide, PaO2 raises and reaches the plateau within about 10 to 15 minutes once the insufflation of carbon dioxide is initiated. This carbon dioxide is readily absorbed from the peritoneum, dissolves and gets excreted through the respiratory system, but this can be monitored using end-tidal carbon dioxide. In a otherwise normal individual, the PaO2 or partial pressure of carbon dioxide and end-tidal carbon dioxide gradient is not that much, and the EtCO2 or the end-tidal carbon dioxide is a very good guide to assess the PaCO2. But in a patient with cardiopulmonary compromise, this does not hold good. The gradient increases and the PaCO2 rise is not readily shown in EtCO2 readings. So therefore we need a continuous monitoring of ABG, using ABG. So what this factor does to the minute ventilation. Minute ventilation under general anesthesia has to increase by about 20% to compensate for the absorption and release of carbon dioxide. So this can be done effectively during general anesthesia under controlled ventilation, but in a regional anesthesia, the patient has to put an effort to excrete this carbon dioxide, and the work of breathing will be very high. It will be uncomfortable for the patient. This is why general anesthesia is preferred in most institutes. These are some of the complications you can expect. These are rare, but still subcutaneous emphysema due to extraperitoneal insufflation, pneumothorax, mediastinum or pneumopericardium can occur through rent in the diaphragm or pleura, and endobronchial intubation. Endobronchial intubation occurs because the increased intra-abdominal pressure pushes the diaphragm upwards and the compliance of the lung goes down, and the trachea that is displaced upwards, so that the endotracheal tube goes into one of the bronchi. So only one side of the lung gets ventilated. This further increases the airway pressure. This further increases the airway pressure and causes desaturation and increased end-tidal carbon dioxide. This has to be identified and immediately corrected by replacing the tube back to its normal position. So you have to check the position of the tube once the pneumoperitoneum is created, and also after the Trendelenburg position and lithotomy position is placed. So at each level, this endotracheal tube migration can happen. Gas embolism is quite rare with carbon dioxide insufflation, but still it is a possibility. It is identified with sudden desaturation and hemodynamic collapse. The end-tidal carbon dioxide comes down, initially goes down transitorily and then comes down abruptly, so indicating that there is no gas exchange. In this situation, you immediately desufflate and introduce a central venous line, put the patient in head down and left decubitus position, and start aspiration of the air. So one other common complication is aspiration of gastric under. This is almost fully this is not possible with a endotracheal tube, cuffed endotracheal tube. Let's look at the hemodynamic changes caused by laparoscopy. Because of increased carbon dioxide absorption, there is activation of sympathetic nervous system. Any surgery will cause release of neurohumoral hormones, which will activate the sympathetic nervous system, but hypercapnia just adds to the problem. So there is increased heart rate, BP and contractility, and the myocardium is sensitized to the development of arrhythmias. And because of intra-abdominal pressure, there is transitory decrease in venous return and myocardial depression due to anesthetic drugs when it is initiated, and due to the reflexes, baroreceptor reflexes, that the hemodynamics come back to normal. So it is most important to maintain the intra-abdominal pressure between 12 to 15 millimeters of mercury. So eventually there will be rise in systemic vascular resistance, which again adds to the increase in heart rate, BP and contractility. The anesthetist behind the head end of the patient will be able to control these factors. The Trendelenburg position. This is named after a German surgeon called Friedrich Trendelenburg in the 19th century. He used this position for abdominal surgeries, but many of our gynecological procedures happen with both Trendelenburg and lithotomy. Both put together, we are using this position, and it is ideal to place the patient with head down of 15 to 30 degrees and not more. The cephalad displacement of viscera and impaired diaphragmatic function, which is already present with pneumoperitoneum and raised intra-abdominal pressure, this is accentuated with this position. So again, the patient predisposes for development of atelectasis And like I said earlier, the endobronchial intubation can occur, and the position of the endotracheal tube has to be checked after final position and before surgical intervention. So at each level, endotracheal tube position has to be checked. So there is a rise in cardiac output and central venous pressure in this position, but in course of time, within about 10 minutes, it comes back to baseline because of the work of baroreceptors. So it is very important to avoid nerve injuries. This position can cause nerve injuries. Documented nerve injuries have occurred, especially brachial plexus injury at the level of head of the humerus. So adequate padding is needed. The patient in head-on position should not slide down, so anti-slide mattress is needed, or strapping can be done, and the strapping should not be so tight to impede the movement of chest. So the hands are better kept at the sides with adequate padding to avoid ulnar injury. And this regarding lithotomy position, this is where the team, which includes our technicians, comes in. A well-trained technician is always necessary, because this lithotomy position has to be done in such a way that both the legs are raised together and put on the support. Otherwise, you can have lumbar disc injury. So these legs, they need to be padded, and always look to avoid the common peroneal nerve injury at the level of fibular head. So when you put the patient in lithotomy position, again there is initially there is draining of blood from the lower limbs towards the heart, and there is a transient increase in cardiac output, which again settles back to baseline once the baroreceptors come into play. One devastating complication which can occur with lithotomy position not done properly is compartment syndrome. Compartment syndrome arises because reduction in arterial blood supply due to the position, and also impedance of venous blood flow away from the leg. So this can cause compartment syndrome, which has been documented very well all over the world. So in prolonged surgeries, make sure that the legs are padded well, and if it is, you can release the, if possible, you can release the leg and put into neutral position every 2 hours or so. So any acute complications, the sudden hemodynamic collapse can occur in many situations, like hemorrhage, injury to a major vessel. This has to be managed surgically, possibly through laparotomy. Pneumothorax can occur because of increased airway pressure, and or a bulla, emphysematous bulla can rupture during the course of surgery and cause pneumothorax. Whatever the reason, these patients need post-op ventilation. If this pneumothorax turns into a tension pneumothorax, it has to be treated immediately with intercostal drainage or through a needle. So gas embolism I have already discussed. This can also cause sudden hemodynamic collapse. The treatment of which is again head-on position, left decubitus, CVP line, 100% oxygen, removal of pneumoperitoneum, etc. So vasopressin has been used widely in myomectomies, laparoscopic myomectomies. The dosage is, you dilute 10 international units in 100 ml of normal saline, and inject up to 40 ml, like 4 international units, and the injection has to be in the right plane with negative aspiration for blood each time you inject, and it is usually considered safe. There are studies for and against vasopressin infiltration in myomectomies, uh, but if at all toxicity occurs, it presents like peripheral vasoconstriction, bradycardia, hypotension, and reduced cardiac output. So, since there is peripheral vasoconstriction, the anesthetist picks it up as loss of pulse in the pulse oximeter, and the first tendency is to use vasoconstrictors. That is something which you should never do. Here, the treatment is cardiac life support and atropine. Never use vasoconstrictors. Postoperative care. Though there is less muscle trauma on incisional plane than open procedure, pulmonary dysfunction does occur. It occurs for at least 24 hours. There is reduced FPC, FEV1, FRC. The reduction is up to 25%. So, as compared to 50% in open cases. This is due to diaphragmatic tension due to pneumoperitoneum. Here, postoperative analgesia plays a very big role, because this pulmonary dysfunction, the patient to come out of the pulmonary dysfunction, post-op analgesia is very important. If the patient has pain, this will only add to the pulmonary dysfunction. So, post-op analgesia, what we employ is balanced analgesia using opioids, local infiltration at the port sites, or transversus abdominis plane block, or the combination of all. Of course, post-operative nausea, vomiting, this is more with general anesthesia than regional anesthesia. A well-prepared patient and with proper anti-aspiration prophylaxis and prokinetic agents, we will be able to manage. So again, lastly, we do have pregnant patients who present for non-gynecological and non-obstetric surgeries. The ideal time would be the second trimester, when organogenesis is all over and there is still space to create pneumoperitoneum for surgical manipulation. So, what's the difference between pregnant lady and others? These patients usually need DVT prophylaxis. You need uterine displacement when she lies in the supine position, and we employ what is called rapid sequence induction to avoid gastric aspiration. And NG tube here is mandatory. The monitors, apart from the other monitors listed earlier, this patient needs fetal heart rate monitor also. Routine tocolysis is not recommended, and it is reserved for individual patient. On an individual basis, you can decide whether she needs tocolysis or not. So it's always a teamwork. The team consists of not only the anesthetist and surgeon, but also the theater technicians, the scrub nurse, the circulating nurse. Everybody plays a role in avoiding complications. And I would stress upon the fact that we should all continue to document everything and fill up all the checklists during and after surgeries. Thank you.
Thank you, sir, for such an elaborate topic, which you made it very simplified way. Thank you so much.
Thank you, ma'am.
Ma'am, unmute yourself.
Yeah, thank you so much, sir. As gynecologists, we are always looking at the foot end, and then we are not aware of what is happening at the head end of the patient. And you have very nicely, in a very comprehensive manner, dealt with all the complications which could be associated with the anesthesia. And as more and more advanced surgical work is happening in the field of gynec laparoscopy, anesthesia becomes a very, very vital role. So, in fact, what is your take on combining general anesthesia with the spinal anesthesia for laparoscopic surgery?
Ma'am, general anesthesia with spinal. General anesthesia with spinal will cause hypotension. Hypotension. Epidural just does make sense. It can be used for post-operative pain relief also, continued in the post-operative period, and the bowel distension and all that is reduced to an extent in with epidural anesthesia combined with GA.
So, can we have the discussion towards the end of the session? Can you please stay back with us, sir?
Sure, ma'am.
Thank you. So we move on to the next presentation. So the very important topic again. So the port entry is definitely associated with many complications, and we don't have any safe technique to describe that it is free from any kind of a complications. All kind of entry is associated with the complications, but it is only that how we are going to identify these complications and manage them effectively in the intraoperative period rather than in the post-operative period is what is going to define the outcome of the particular complications. So to address on this important topic, we have Dr. Madhubala here with us. And to introduce Dr. Madhubala and to chair the session, we have Dr. Padma, who is an eminent endoscopic surgeon from Madurai Meenakshi Hospital, Mission Hospital, Madurai. And she is the HOD of the department. And she is not only a laparoscopic surgeon, but also a robotic surgeon and also a gynec oncologist. So over to Dr. Padma to take over the session.
Good evening, everyone. Am I audible?
Yeah, very well.
Yeah. I have to congratulate you, Mala, and the IAG team. And once again, thanks for getting me inside the program today. And as you rightly said, whether it's a simple lap or a complex procedure, laparoscopic procedure, the first step is to gain entry into the peritoneal cavity. And we all know it is a blind procedure. The primary port always is a blind procedure. But even sometimes, the secondary port also, when we are trying to introduce it under vision, also complications do occur. And today we have Dr. Madhubala, an eminent laparoscopic surgeon from Tirunelveli in South Tamil Nadu. She's a senior consultant at Lakshmi Madhavan Hospital, which is a DNB training institute. And her main fields of interest are high-risk obstetrics, laparoscopic, hysteroscopic surgery, and infertility. Over to you, Madhubala.
Thank you, Dr. Padma. And let me thank Dr. Malaraj and IAG team for giving me this opportunity. The topic given to me, as you said rightly, it's very important because abdominal access and creation of pneumoperitoneum is the key for any laparoscopic surgery. And this is unique to laparoscopic surgery, which is not seen in any open surgeries. So the entry should be smooth without any problems so that our proposed or planned surgery can be carried out smoothly. So what is a safe entry? There should be an entry to free peritoneal cavity, and there should be no injury to major vessels or any other viscus. So for universal steps which are taken for a safe access would be a well anesthetized patient and a cooperative anesthetist, a relaxed abdomen with an empty stomach and bladder, a well-prepared bowel, and an experienced team and excellent equipments which the surgeon is familiar with, and he or she should be able to know the equipment, how does it work and everything. So the access-related injuries can be during the insertion of Veress needle and also during the insertion of direct trocars, which is being followed mostly nowadays. Again, injuries to the vessel and to the viscus. There are lots of evolution of trocars from various pneumoperitoneum trocar to closed entry, open technique, and to trocarless reusable visual access cannula. We are seeing so many types of trocars. It means that we don't have a safety trocar as such. Each and every patient should be individualized, and then the usage of trocars is according to the surgeon's choice and comfort. So the major complications at the time of entry would be roughly around 1.4 per 100,000 procedures, whereas major vascular injuries is 0.4 per 1,000, bowel injuries are 0.7, and direct entry 0.5. Even with Veress needle entry, it is 0.9 per 1,000 because everything, as you said, it's blind. So peritoneal entry So as we enter, the varus needle is crossing the skin, subcutaneous fascia, anterior rectus sheath, linea alba, and the posterior rectus sheath, and the peritoneum. So how do you know that we are in the peritoneum? There are lots of tests being advocated when we introduce the varus needle. But one important thing what we should know is we should see the insufflation pressure, which will be less than 10 millimeters of mercury. And this is the foolproof test that the tip of the needle is inside the peritoneal cavity. And then the abdomen is insufflated and we can tap and see the fullness of the abdomen. So insertion of varus needle, still people use this pop test and drop test, and the lateral needle swing is seen when it is not inside the peritoneum. The arc is too much because it doesn't have resistance from the tissues. When it is the tip is inside the peritoneum, the tissues give resistance, so there is a smaller arc. But whatever said and done, the most valuable test is to observe the actual insufflation pressure to be 8 millimeter or less, and the gas is flowing freely. So after putting the needle, we should not waggle the needle, because even a small 1.6 millimeter puncture can become a 1 centimeter in a viscera or a bowel or blood vessels. So another important thing is the placement of varus needle according to the BMI of the patients. So in a thin patient, it should be placed at a 45-degree angle. And in overweight patients, it should be placed at an angle of 45 to 90 degrees. And in obese patients, at the almost perpendicular to 90 degrees. Why so? Because the bifurcation of aorta is almost 0.4 centimeters caudal to the umbilicus and in a thin patient, and it is 2.9 centimeters caudal in an obese patient. So you can have 90-degree perpendicular axis in an obese or obese woman, and it has to be a slanting so that it don't hit straight into the aorta in case of thin women. So direct trocar entry, as we said, it is mostly used by many surgeons. The trocar is actually, it is the same as varus needle, but we don't do any test. It crosses all the layers of the abdominal wall and enters the peritoneal cavity. But the surgeon has to be experienced, and the index finger should guide the entry properly so that you place your trocar freely into the peritoneal cavity. The most common thing which everybody would have faced will be the subcutaneous and the subfacial emphysema and edema. It is because of the improper insertion of the needle, which will loosen the parietal peritoneum, and our carbon dioxide infiltrates the loose areolar tissue, which creates this subcutaneous and subfacial emphysema. But we don't have to worry about this. Initially, there will be a difficulty in visualizing the pelvis, but this rapidly gets resolved in 2 to 4 hours. The next thing we should be careful during entry is the incidence of adhesions. So even when there is no previous injury, the incidence is around 0.6%. And in cases of previous laparoscopy or laparotomy through either fan and steel or midline, the incidence ranges from 16 to 50%. So we have to predict the adhesions by looking at the scars. Sometimes the adhesions can be further away from the scar, or sometimes it may be right under the scar itself. So adhesions is also present in 10% of cases in cases of virgin abdomen, and sonographic mapping sometimes might be helpful. When there are previous abdominal surgeries, we can always choose alternative sites like the left upper quadrant, which is also called the Palmer's point, which is 4 centimeters below the left subcostal margin. And also you can choose the right lower quadrant point in cases of upper abdominal surgeries. The primary trocar should be very important, because as you get inside and see the abdominal wall, then you can plan your secondary trocar. So whichever site you think that you're comfortable without adhesions, then that site might be chosen. The safety points should also be noted when putting in the primary trocar. Even in the right lateral quadrant, it has to be away 5 to 8 centimeters away from the midline. So this is one Palmer's point. Here the patient had a longitudinal lower abdominal scar, and she was for hysterectomy. And we chose the Palmer's point with the direct trocar entry, thinking that we might be facing some adhesions. She was a thin patient also. So insufflation was done, and tapping was done, and we could see the fullness of the abdomen. And sometimes, very surprisingly, as you put in the scope and get inside, you can see a very clean abdomen, which is really fortunate and sometimes very rare. This will always not be there in all surgeries. You have to expect some types of additions, thanks to the patient and to the surgeon who has done it. So the thing what we worry about is the major vascular injuries. So vascular injuries can occur in the abdominal wall on the inferior epigastric artery, injuring it. Intraperitoneal omental vessels or mesenteric vessels can get injured. Retroperitoneal, our main aorta, IVC, and iliac vessels should be kept in mind. So inferior epigastric artery sometimes might be a very problematic bleeder when you touch it or when you perforate it. It goes right beneath the rectus muscle, and always it has to be kept in mind when you're inserting your secondary trocar. The superficial ones can be seen with the trans illumination, but this deep inferior epigastric artery, we should go away from the rectus muscle, mainly 8 centimeters away from the midline, so that you don't perforate or injure the deep epigastric artery. So what if there's a bleeding in the inferior epigastric artery? Where anyway we have to tackle either by diathermy or figure of 8 stitch or a Foley's balloon tamponade. So how to identify? To avoid this deep inferior epigastric artery, we have to identify the round ligament, and this artery travels medial to the entry of the round ligament into the inguinal canal. So we have to avoid medially and then go laterally to the round ligament so that we don't injure this important vessel. Of course, superficial vessels are avoided by the transillumination test. Here we can see the insertion of the round ligament and the blue colored inferior epigastric vessels, and the trocar is placed very much lateral to the round ligament, avoiding the inferior epigastric artery. This should be the port placement when you're looking at the inferior epigastric artery. So the vascular injuries can cause 15% of mortality. And why we are worried is because of its proximity of the anterior abdominal wall to the retroperitoneal structures. The distal aorta and the right common iliac artery, they lie directly below the umbilicus, so we should not injure them at any cost. So as we have seen, according to the BMI, the needle placement should be there. The distance from the entry point to the aorta is only 0.4 centimeters in normal women. That is why we should not go perpendicular so that we will hit the aorta. We have to go 45 degrees angle. We should have a 45 degrees angle when you insert the trocar. And in case of overweight women, it is 2.4 and 2.9 centimeters in cases of obese patients. So the angulation should be different in these individuals. So when you have an injury to these vessels, most of the times the carbon dioxide, what is there inside the peritoneum, can tamponate the vessel, and we will not see it immediately. But only when the pressure normalizes, the bleeding will start. So how to manage? We have to cut open the peritoneum with scissors or with carbon dioxide laser if you have one. Evacuation of hematoma and application of vascular clamps. An experienced surgeon can do the suturing laparoscopically, or definitely we have to call for help, and also a laparotomy if needed. So it can present with shock, hemorrhage, or a retroperitoneal hematoma, and also carbon dioxide embolism. This is the case where this patient, the surgery was started, and then suddenly we can see a gush of blood inside a retroperitoneal hematoma. So we have to resort to the next methods. You call a surgeon, or you can suture it by yourself if you are well versed with it. These are the vascular clamps. These vascular clamps should be in your operation theater armamentarium. Either you use it or not, they have to be there, because we don't know at which time we'll be having the need of them. And these are the laparoscopic vascular clamps. Management, it is easy to say don't panic, but the only thing is our heart will be in our mouth, but we should not remove the trocar. The trocar should be in situ. We should seek for help, arrange a team, arrange for blood, and then if you're not well versed with the laparoscopic sutures, immediate laparotomy and vascular control. We have stalwarts here in this session talking about all these injuries, so we don't have to go in detail. So to avoid all these injuries, there is succession of evolution of trocars, and one such is the optical trocar entry, where the trocar is placed along with the telescope and it is inserted directly so that the telescope sees the trocar entering each and every layer of the abdominal wall so that the entry would be safe. Then came the Hassan's method of open cannulation method, which is introduced by Harith Hassan in 1971, which is also called a safe entry of laparoscopy. So in open trocar placement, the trocar is placed, there is an incision made from the skin to the peritoneum and the trocar is placed under vision. So we need additional instruments like retractor, hemostats, and suture materials. A vertical incision is created and the epidermis is incised and pulled in, and the extension of the skin incision is done. A sharp dissection is done with the abdominal layers. There is no blunt dissection, and peritoneum is held with the instruments and it is opened directly under vision. And the fascia is held with suture materials, and then the trocar is introduced. So this suture materials helps to slow down the gas flow and also keep the trocar under place and reduces the airflow also. So this open technique eliminates the risk of major vascular injury, reduces the chance. It doesn't eliminate the chance of bowel injury, but when you're catching the bowel, when you're catching the peritoneum, sometimes the bowel adherence may be there so that the bowels can get injured. So reduces the chance of bowel injury, but you can rectify and recognize and rectify the bowel penetration according to Hassan in 1971. The next important injuries, what we should be worried about is the bowel injuries, which is the third cause of death. Mostly they go unrecognized and has a delayed presentation with peritonitis. The incidence can be from 39.8% to 22% with primary and secondary trocars. So the time and cause of bowel injuries can be during the variosteal insertion, during primary trocar and secondary trocar, or while doing the dissection and retraction with the instruments and of course with the diathermy use. A distended stomach because of hyperventilation can also be a reason for injury of the bowel. Trocar or variosteal injury, we have to diagnose. How do you diagnose? There will be emanation of foul-smelling gas, and you can see the GI contents at the tip of the needle. So management is you can do a mini lap and two-layer closure. Laparoscopically, a purse string suture in the seromuscular layer surrounding the defect can be done. Laparoscopic staplers are also used to suture. If you have one, you can use it. And post-operatively, patients should be kept under nil oral and a nasogastric tube drainage for 2 to 4 days according to the condition. This is the gastrointestinal anastomosing device, which will suture. You can see the auto suture written on it. When you have one, this is a luxury. Many of the advanced laparoscopic surgeons will have this and they'll suture the bowels. Injury to the small intestine, again, can be in the umbilical site or lower quadrant trocars can cause this. It is always recognized in a later stage. Management, you have to avoid the adhesions area and choose a higher site for the secondary trocar. Perforation is repaired transversely laparoscopically, and the bowel can also be withdrawn through a 10 mm trocar and sutured and repaired outside and pushed in. This is how the bowel is pulled outside the 10 mm trocar and sutured and pushed in. This is a patient with posted for diagnostic laparoscopy, where the primary trocar accidentally was there inside the bowel loops because all the bowel loops were sitting on the anterior abdominal wall. So all the adhesions were released and the bowel was sutured laparoscopically. We can see the primary trocar inserted into the loop of bowel loops. All the bowels are matted together and she turned out to be a case of Cox. So next one is air embolism. Dr. Niranjan has talked in detail. This is because a needle within a vessel or a liver or an exposed vascular area or because of the organ plasma coagulation. Recognizing with hypotension and hypoxia, sudden drop in EtCO2 and Melville murmur is heard. And how to manage? We have to stop the pneumoperitoneum, vent it out, head down and left lateral position, and a central line is instilled so that we can aspirate the air. Bladder injuries can happen during the secondary trocars and should be dealt in accordingly. We have Again, a stalwart talking about this later. So the factors responsible for trocar injuries will be an inexperienced or unskilled surgeon, failure to sharpen or to elevate the stabilize the abdominal wall, perpendicular insertion of the needle or trocar without looking into the BMI of the patient, lateral deviation of the needle or trocar, inadequate pneumoperitoneum, a forceful thrust, or a failure to note anatomical landmarks, or inadequate incision size. Inadequate incision size can also make you to do a forceful thrust and it goes and hits a vessel or a viscus. So take-home points for a safe entry would be when you enter the abdominal cavity, the actual insufflation pressure should be 8 millimeter or less, either with the needle entry or with the trocar entry, and the gas is flowing freely. Various insertion angles should be kept in mind in different BMI patients. And adequate pneumoperitoneum is the key. Volume of 1 to 4 liters depending on BMI and parity should be given inside. Pressure of 10 to 15 millimeters of intraperitoneal pressure should be achieved. But of late, the high intraperitoneal pressure of 20 to 25 millimeter splints the abdominal wall and maintains a distance of around 4 centimeters from the abdominal contents. And this is advocated for the initial few minutes so that you place in your trocars and then you can reduce the pressure to 10 to 15 millimeters of mercury. This short increase of intraperitoneal pressure time will not have any adverse effects according to data. So it also increases the distance between the umbilicus and the bifurcation of aorta from 0.6 centimeters to 5.9 centimeters. So conclusions. Complications occur even in best of hands and should be recognized and addressed immediately. Proper training and experience always matters. Troubleshooting guidelines are mandatory in each and every setup. Converting into open should not be seen as a failure. So no single technique or instrument has been proved to eliminate laparoscopic entry associated injury. We should have proper evaluation of women supported by surgical skills and good knowledge of the technology and instrumentation, which will be the keystone to safe access and prevention of complications. Thank you. Thanks for patient listening.
Yeah, please unmute Dr. Padma.
Yeah, that was a very nice presentation, Dr. Madhubala. It was really brought out all the important salient points regarding the various needle insertion, the intra-abdominal pressure, what to do in case of an addition, vascular injuries, bowel and bladder injuries. And I mean, I personally have done nearly more than 10,000, but in recently now, one of the cases, as she was putting in the viris, the patient just bucked. She was light and she just bucked. And the viris straight went into the stomach, which was distended. So all these things we do face. And so to avoid complications, we should not be doing surgeries. But the only thing is, as you say, we need to be bold. But then when a difficult situation arises, even a best surgeon may lose the cool a little at that time. But a calm mind always helps us in overcoming that. Very nicely said. Thank you.
Thank you.
So very nicely you have highlighted like what alternative ports also we need to have in mind and try those things also, not just to one site. And also alternative techniques also, I feel like see basically you have to be comfortable with whatever you're doing and you have to literally master that particular technique. If you see in my hand, if you see endotip entry is the best option in my hand. So I don't create pneumoperitoneum, direct endotrip under vision has been quite comfortable all these while. But then like that, you have to just get comfortable with each and every technique and then master it ultimately. How about Jane's Point? Have you ever tried Jane's Point by Dr. Nuthan James?
Yeah, it is 10 centimeters away from the umbilicus at the left intercostal region, costal margin, no, supraclavicular line. Most of the times, my second trocar will be, accessory trocar will be in that point. So that ipsilateral ports, one will be the Jane point and one will be the lower quadrant point above the anterior superior iliac spine, because that is the most avascular point, we can say.
Yeah.
Jane point. So it is better when there are multiple scars in the anterior abdominal wall. they can resort to this Jane's Point or the Palmer's Point.
Yeah, so apparently it is
And
vascular structure. So on the left-hand side, I think that is quite safe to utilize when you have a big midline incision.
Yes.
yeah.
So how about
And can I add something, Mala? And another important thing is depends on the pathology also. Like suppose there are large ovarian tumors, a pregnant uterus, then we have to take adequate care just by trying to be above that mass lesion, and always trying to do an open entry technique, especially when there is large ovarian cyst. You don't want to spill the contents and other things. And same thing with a vascular uterus when in a pregnant lady. When we try to deal problems like a torsion ovary and other things. So that is another thing, other things we have to keep in mind.
yeah, the Lehan point in between the umbilicus and the zipisternum. No, we go so close to the zipisternum
Yeah,
in such cases, but only thing is we have to make sure that the stomach is really flat.
yeah.
That is one thing we need to keep in mind. So very well covered, Dr. Madhu. So I think we will move on to the next topic, and please stay back until the end of the session. We'll take questions from the audience at the end of the sessions.
Definitely.
Thank you so much. Thank you so much, Dr. Padma and Dr. Madhubala, for your valuable time and inputs. So we move on.
Thank you.
So we move on to the next topic, which is again a very important one, the bladder complications, intra and post-operative. How are we going to prevent and also manage them? So as more and more cesarean sections are being performed, and when these women come for our laparoscopic procedure, especially when it associated with TLH, we encounter lots of bladder complications. In such a scenario, the right technique is what is really going to help us to sail through safely, because once the complication is done and if it is not identified, it becomes a big headache, not only for the patient but also for the surgeon. And though bladder is a very, very friendly organ, but if it is not treated properly, it can turn out to be a real big foe. So we need to treat it with respect. And here we have Dr. Rishikesh Pandit, who is going to highlight on the various aspects of how we exactly going to tackle the bladder complications, and also how to prevent these injury in the first instance. So before we move on to the topic, I have a very important announcement for all of us. We have a very important international conference which is coming up next year, 2024. That is from August 29th to September 1st. That is the Apache conference, and the Chennai is hosting this conference, and lots of efforts are being made for this conference. There is a big force working behind this conference, and we are looking forward for all your valuable participation. So kindly save and block the date between September 29th to the 1st of September 2024. So we move on to the topic with bladder complication with Dr. Rishikesh Pandit, for which I would like to welcome our chairperson, Dr. Renu Singh Lata. She is from Kanpur, an endoscopic surgeon, and also she is very, very keen on training and has various fellowship programs to her credit. She is not only a laparoscopic surgeon, but also a robotic and fertility specialist. So over to Dr. Renu Singh to introduce Dr. Rishikesh Pandit and to take over the session, please.
Thank you, Mala, and I must congratulate you all for conducting such an important topic, and that too in a webinar in a very small time. So both the sessions were wonderful. I was attending the same, and indeed this next topic is going to be very great. And we have indeed the prodigy amongst us, the young prodigy, Dr. Rishikesh Pandit. He is from Ahmedabad, and we're talking and how to deal the bladder complications. So rather than taking much of his time, I think Dr. Rishikesh Pandit, you are on. Dr. Rishikesh, are you there?
Yeah, he is there. Can you please share your presentation?
Hello.
Rishikesh sir, kindly unmute.
Yeah, he's there. Yeah. So we welcome Dr. Rishikesh, and kindly go ahead with the bladder complications, intra and post-operative identification and its management. Indeed, it is always great to recognize these complications during surgery and manage them. So it really saves you a lot of time and patience agony as well.
Rishikesh sir, kindly unmute. I have sent you the notification. Just click on that.
So in laparoscopic surgeries, because of use of so many types of different energy sources, these bladder complications and ureteric complications often get unnoticed and they present later on, sometimes after a week or maybe even after 3 weeks. The ureteric complications they present even after 3 weeks, and sometimes they present as very weird as urinoma also. A simple cyst patients presents with lot of pain and fever. And then these patients been diagnosed as urinoma due to presence of cyst because of stricture of ureter. So these are the different type of complications. There are different varied complications they can appear, which we have to keep in mind. And definitely with use of energy sources, we have to be very, very careful. And we should know what is going to be the lateral thermal damage. Dr. Rishikesh, are you there?
Yes, ma'am. Hello.
Kindly go ahead. I was just we were just
Yes, sir,
waiting for you,
please.
so I was just waiting. Yeah, kindly go ahead. Yeah.
So first of all, thank you, Iage, all office bearers, Dr. Pandit Paraskar sir, Malaraj ma'am, Dr. Kalyan sir, to giving me the opportunity to present my work here. So we should go ahead with the presentation. So the prevention is always better than the facing the complication. So with the first thing, if we visualize better, we can always detect the structure and go ahead safely with the surgeries. So the visualization gets better with the HD scope, 3D and 4K. The 3D is giving you the depth perception, so it is always better to dissect in a proper plane. Second most important thing is the electrosurgical unit. So if you are using the monopolar energy for the vault opening close to the bladder, then try to use the cutting current rather than using the coagulation, as it's having the more lateral spread. Similarly, if you are using the bipolar shearer, the entire lateral spread is entirely depending on the how much time you are going to spend on the tissue. Third thing you can use is the sound energy, which is the harmonic, which is also a safer way to dissect close to the bladder. Third thing is the while dissecting the bladder, the proper traction on the uterus and the bladder is the important thing. Fourth thing is the adequate bladder dissection. That means when you visualize the bulge of the cervix, still you have to dissect the bladder for at least 0.5 to 1 centimeter, which is going to help for your suturing also and avoiding the lateral spread damage to the bladder also. The bladder dissection becomes challenging in cases of previous LSCS, scar ectopic pregnancy, when you are dealing laparoscopically, when you are doing the wall prolapse surgeries, implanting the mesh over the vagina, and the endometriosis cases. The technique which we can use to prevent the complications are the lateral window technique, retrograde technique of the bladder dissection, and the third, dissection of the paravesical space, enter the virgin plane, and then come from virgin plane to the adherent portions. So these are the techniques. So the lateral window technique we are using in cases of previous LSCS, where you can visualize entirely ventrofix uterus. Generally, when you do the initial idialysis, you get a free plane. That is because of the involution of the uterus. Uterus get fixed to the fundus. Then the involuting portion don't have the adhesions. And then again, you get the bladder adhesions. So first, start the dissection with the identification of the round ligament. Cut the bilateral round ligaments. The most important structure you can visualize is the uterine artery. Once you visualize the uterine artery, still you can have to go caudally to enter between the vesicovaginal plane. Another important thing about the advisualisis is that the proper traction and small neck. So with the small neck, CO2 is going to enter into the plane, and you are going to just tap into this vascular plane to enter into the proper bladder and between the vagina. So here I am showing you after the adhesiolysis of the fundus, we are going to take the coronal structure and the round ligament. At the time of lateral window creation, just dissect anterior to the uterine. You use your left hand to lift the bladder and try to visualize the vertical capillaries. Once you visualize these vertical capillaries, that means you are in a proper plane. Then you have to give the traction on the bladder and dissect over the uterus. The curve of the shearer is towards the uterus. If you are using the sound energy, then the active blade should come from the uterus into the free space. Another important thing is the dissection of the bladder pillars. Bladder pillars are the fibers which are over the uterine vessel. So you have to clear bladder pillars also. Don't rub on the vagina or the bladder. You have to always put the shearer or the your right hand instrument into the bubbles. So if you dissect the bladder pillars properly, entire bladder is going to go down. The complication will occur when you coagulate the uterine artery and cut, and if it bleeds, still you have to go lateral to coagulate it, and then it causes the lateral spread and the damage to the bladder. If you are not able to do the bladder dissection with the lateral window technique, then should go for the retrograde technique, where you have to first cut the posterior leaf of the broad ligament and go till the level of uterosacral. Here, she is previous only one LACS case, but still we are not able to enter either through the midline incision or through the lateral window technique. Try to learn the identifying the structure by its capillary and its texture. So here I'm not visualizing any kind of vertical capillaries, so I am not in proper vesicovaginal plane. Here I am attempting for the lateral window technique, but it's in vain. So after dissecting the right side bladder pillar, here we can visualize the right sided uterine artery. So as we are not able to do the lateral window technique, we have decided to go with the retrograde technique. Here you can visualize as we are dissecting in a wrong plane, it started bleeding. So as the uterines are skeletonized, we are just taking, sealing and cutting the uterine and goes on continuing the cut into the Macken rods till the uterosacral. And after cutting the uterosacral, we are going to open the vault posteriorly, remain close to the cervix, one uterosacral to the other. Once we cut the posterior vault, we have to dissect close to the cervix into the anterior fornix till we get a free plane. Try to observe my left hand is continuously giving the traction on the cervix to dissect just flush between the cervix and the bladder. Here I can feel the loss of resistance as I cut into the proper plane. Once you feel that loss of resistance, it's easy to just tap over the cervix between the bladder and the cervix. So this is the plane which we want to enter from the above, but we are not. So we are separating the bladder from the vagina by the retrograde technique. So this should be the last thing you should attempt. So this is the entire bladder, which is intact. But if the complication has had happened, then what you can visualize is the direct Foley's catheter through the bladder. The CO2 gets filled in the urobladder. You can see the hematuria. If the injury is really small, you're not able to identify, you can feel the methylene blue dye in the bladder, or you can do the cystoscopy. In the cystoscopy, you can see the thermal damage by the blanching of the tissue. So if you diagnose the injury on table, the principle which you are supposed to use to repair the bladder are the first, dissect the posterior bladder wall to achieve the tension-free suturing. Second thing, excise the thermal injury site because that is going to slough off. Third is the use of either 20 bar suture or 30 vicryl. The benefit of the barb over the vicryl is that it is going to give you the proper uniform tension over the suture line. And the last one is the omental graft interpositioning. Patient present to you on the mostly from 8 to 12 day with the complaining of continuous urinary leak, incontinence. You have to evaluate first with the perspeculum examination. You can do 3 swab tests with the methylene blue or a double dye test, that is with the methylene blue or a pyridium. If it's a ureteric fistula, then we get an orange dye on the cotton. If we are getting the methyl blue dye on the cotton, it's mostly the VVF. Another choice of investigation is the CT urography, which gives you the idea of the location of the fistula as well as the number of the fistula. Next, the evaluation with the cystoscopy. Here you can visualize the location, proximity with to the ureter, and sometimes patient is having really small leak. That time you have to perform the vaginoscopy with the filling of the bladder with the methylene blue. So you can diagnose the small leak which is going to occur through the fistula site. For the management, when you're opting for the delayed surgical approach, it's crucial to attain the sanitary protection and the skin care. Approximately 10% of cases witness spontaneous closure within 15 days to 2 months with just an urethral catheterization and the anticholinergic drugs, particularly when the fistula is small and detected early. When we have decided to go for the surgical management, there are 3 approaches. One is an extraperitoneal, second is intraperitoneal, that is either you can do it open, laparoscopic, and the third is the vaginal approach. So the classification, simple vesicovaginal fistula are smaller than 0.5 centimeter, found in non-radiated patients with no evidence of malignancy involvement. Intermediate fistulas are between 0.5 to 2.5 centimeter. Complex vaginal fistulas are more than 2.5 centimeter. So here I'm going to present you the laparoscopic VVF repair. The first step is to perform the cystoscopy. Try to identify the fistula site, its approximation from the ureter, cannulate the fistula tract, then, if needed, cannulate bilateral ureters. Try to use different colors of digestant and the cannulation catheter. As I told you prior, if fistula is away from the ureters, there is no need of cannulation. Then come for the laparoscopic adhesiolysis, as it is going to form the urinoma in the abdomen. There is going to be lot of adhesions. The ideal time for the repair of VBF is at least 40 days after the surgery, where you can visualize complete subsided inflammation. So there are two techniques by which you can do the cystostomy. One is the transverse cystostomy, and another is the O-corner technique, where we can completely biwall the ureter. Here I am showing the transverse cystostomy. Mark the fistula tract. This marking gives you the complete idea till what level you have to excise the fistula tract. Do the sharp dissection between the bladder and the vagina. Free the bladder from the vagina at least 1 centimeter so that you can suture the bladder properly. The advantage of the transverse cystostomy is that you can easily, early, fast reach on the fistula tract. It is a smaller incision than the O-corner technique. Then here I'm going to close the vagina vertically and the bladder transversely. So I'm showing you the closure of the vagina vertically. The intention behind that to minimize the contact between the two suture lines. Here I'm going to use 20 barb suture for closure of the cystostomy. While taking the sutures, you have to take thick muscularis, thin mucosa. Again, from the thin mucosa, take out the needle from the thick muscularis. So when you tighten, it is going to form a triangular shape, and it is going to help you to achieve watertight closure. You can suture the bladder either in one layer or a two layer. After that, we are going to check with the methylene blue dye for the water tightness. Do not instill more than 150 cc methylene blue dye, as it is going to cause tension on the suture line. The last step is that the omental placement between the bladder and the vagina. This is going to give you additional vascularity, creating a lymphatic channel and a barrier between the vagina and the bladder.
Dr. Rishikesh, a wonderful presentation definitely is going on, but we are actually short of time, dear friend. The time allocated is 10 minutes more to you. We have many other speakers, so just kindly fast forward little things, yeah?
So the another technique is with the rotational flap technique. This we are going to use in cases of post-radiation fistulas, where we can increase the vascularity of the fistula tract by pulling the dome into the fistula tract. For the vaginal repair, this is the first picture where you can see the inflammation immediately after the fistula. Second, after the subsidization of the inflammation, and third, with is the last picture that is after the repair. So the prognosis and the complication, the continuous bladder drainage with the catheterization for 4 weeks with anticholinergic drugs is important. There are almost 30% chances of recurrence. There are chances of urgency and the bladder volume reduction. But still, if you first attempt you repair it properly, you can achieve the good result. Thank you.
Thank you, Dr. Rishikesh. Indeed, it was a wonderful presentation. And with bladder complication, you taught us even the VVF repair and it was beautifully presented. Indeed, for any prevention of complications, specifically in laparoscopy, what is most important thing is the planes. So if we identify the plane, the vesicovaginal space, the vesicovaginal area, which we have to dissect, it can be by any approach. It can be by anterior, lateral, posterior, whatever approach it is. And then the judicious use of energy sources is something which is very much need to be emphasized. Whatever energy source you are using, you have to be very cautious how it is to be used, what is going to be the lateral thermal damage, whether you have to keep the paddle for a longer period of time, and what all complication they can happen with different type of energy sources. So, and sooner the better. It is good to identify on the table rather than waiting it to be happening later on. So it was indeed a wonderful one. And I think the audience questions will be taken in the last. So please stay with us. Thank you. Thank you so much.
Thank you, ma'am.
That was indeed a beautiful session and a lovely surgery, Dr. Rishikesh Pandit. It was really excellent to watch your surgeries. And so thank you so much, Dr. Rishikesh Pandit and Dr. Renu Singh for taking this session very beautifully and in a very nice manner. So again, to continue with this thread, we have a very important topic again with the urinary tract injuries. We have the ureteric injuries, which is again very, very common, which we are encountering now as more and more endometriosis surgeries are happening. And when we get an endometriosis surgery, now we see that most of the time it is only severe endometriosis with involvement. So to talk on this particular topic, we have a very eminent endoscopic surgeon, the legend in endoscopy, Dr. PG Paul. And to chair this session, we have Dr. Prabha Desai from Karnataka, who's an renowned endoscopic surgeon. And she is also very keen in teaching, and she does various training programs and fellowship programs. And over to Dr. Prabha Desai to take forward this particular session.
Very good evening. Really, thank you, Dr. Mala Madam, for giving me this opportunity to share such a wonderful talk by such a wonderful and very famous surgeon, one of the pioneers. Who doesn't know Dr. Paul? Actually, he's a very famous, not only in India, but internationally also. And Sir has n number of publications, and he is always a national and speaker. And we know since from our gynae career beginning that he is a teacher for so many teachers in laparoscopy surgeries. So over to you, sir. We are very eager to hear from you about the complications in laparoscopy in pertaining to the ureteric complications. Over to you, sir.
Thank you, Prabha. Good evening, everyone.
Thank you, sir.
I'm happy to be part of this Iage session on complications. Thank you, Mala, for this invitation. I would like to share my screen. You have the screen now?
Yes, sir.
So my topic is prevention and management of ureteric complications. All of us know that one of the most deadliest complication we all initially had was ureteric injuries when we performed laparoscopic hysterectomies. And we know that majority occurs in normal cases, not. I had a ureteric injury long back when I started. Probably it was the 20th case I performed, and that was a perfectly normal pelvic anatomy. And majority are not diagnosed intraoperatively, and all of us know that the commonest litigation. The site of injury, if you look at literature, there is a controversy whether which one is the commonest. But the two commonest ones are, one is lateral to the uterines when you ligate the uterines, or when you are very close to the cardinal ligaments. The other sites are base of infundibulopelvic ligament and uterosacral ligament. And to our surprise, majority of the papers say that almost 70% occurs on the right side. I could not really find out why it happens. Probably the surgeons are standing on the left side. That may be one reason. How do we prevent ureteric injuries? All of us have been taught to identify ureter. So you have to keep the ureter away from your operating area, either by you can visualize, or sometimes we used to have illuminated ureters long back. And nowadays, majority of our youngsters do ureterolysis before when they perform any difficult endometriosis surgery. When we started, we never knew how to do ureterolysis. So we mostly depend on, whenever we start the surgery, first try to visualize. This should be done at the beginning of the surgery when the peritoneum is really transparent. You can really see very easily on the right side, and left side also you can. Majority of the normal anatomy patients, it's quite easy. We are talking about the infundibulopelvic ligament and injury to the ureter. In postmenopausal women, when the infundibulopelvic ligament is less mobile, you can see that if you are not careful, your vessel sealer can be directly on the ureter. So always stretch the infundibulopelvic ligament and then visualize and do the ligation, division and ligation. When we all started, we tried to do illuminated stents. Those were mainly the lighted stents. But now we have the newer generation ones, mainly by the Stryker, where they use near infrared illuminated ones. The old illuminated ones, regular cold light, we could never see the ureter if there is an abnormal anatomy. But this one, this is a demonstration we had. If you put it in the blinking mode, you can actually very clearly identify the ureter, even with an abnormal anatomy. The right side is almost near normal, although it's a case of severe endometriosis. The left side, you can actually watch the ureter once it is blinking. So those who depend on, those who are not trained to do ureteric dissection, probably this is the second alternative to identify the ureter when you perform a difficult endometriosis surgery. Ureterolysis, now we find our youngsters are more experienced than us because we all started late. They all started at the beginning itself. It's comparatively straightforward. In majority of the cases, you can open this lateral triangle or you can go medial to the infundibulopelvic ligament, and you can now identify the extrailiac vessels, the ureter, and you also identify where the uterines arch over the ureter. This is very important when especially you do a surgery like hysterectomy, or when you do an adnexectomy, or when you remove the ovaries, you have to identify the ureter or isolate the ureter before you actually perform the adnexectomy, coagulate and divide the infundibulopelvic ligament. Especially cases with residual ovarian cyst, remnant ovarian cyst, this is a must. You have to really isolate the ureter before you really ligate the. This is just ligating the uterines. We are proceeding with hysterectomy in this case. Now you can see the infundibulopelvic ligament, and you can identify the ureter, which has been already isolated on the left side. Now it's straightforward to coagulate and divide the infundibulopelvic ligament. So now whoever perform endometriosis surgery definitely should know how to perform a safe ureterolysis. Sometimes in severe endometriosis, it can be a very difficult task. It's not that easy like what I am showing at the moment. There will be a lot of fibrosis and to safeguard, and some of them may have hydroureter, where exactly you have to identify the ureter, isolate the ureter, and excise the ureteric nodules. Sorry, the endometriotic nodules. This is one case I performed maybe some 17 years back. This appeared to be a straightforward case, except there were a lot of surface simple adhesions. So in those days case, we rarely isolate and identify the ureter. So we knew that here the anatomy is distorted, and we tried to isolate the ureter. And before actually coagulating and dividing the infundibulopelvic ligament, we really isolated the ureter. Now you can see when I am going to the uterines, and the old principle of remaining very close to the uterus on the ascending branch, I am trying to coagulate and divide with a vessel sealer, the NC. Although I had completely isolated the ureter at the infundibulopelvic ligament, I did not do that when I did the uterines. And after cutting the vault, I had a doubt that whether the ureter is still intact. And to my surprise, I had already transected the ureter. So some intuition that you might have been very close to the ureter. Actually, the ureter was onto the uterus, and then we transected. So if such a ureteric transection happens, what should be the approach to the treatment? If it is more than 5 centimeters from the vesico-uterine junction, a ureteric anastomosis is the better option. If it is very close to the vesico-ureteric junction, then a ureteroneocystostomy may be. And if the loss of ureter is there, probably you need a body flap with a psoas hitch. So in this case, we decided, it's slightly old video you can watch. We identified, we freshened the edges of the coagulated and transected the ureter. We put the ureteric stent, and then we sutured. Although I am using a 3 millimeter instruments, I am using little bigger suture. This is actually 20 vicryl. Probably we should have used a 30 or smaller monofilament suture would have been an ideal one. Although this can be okay, but if it has been now, I would have done with a monofilament smaller suture. So over the stent, the anastomosis was done, and this patient made an uneventful recovery. This is another case of endometriosis, and she had some amount of bowel endometriosis. And in that process, I was trying to isolate the ureter, and something went wrong, whether the isolation of the ureter was done properly, and you can see that accidentally the ureter was transected during the dissection. Although there was involvement of the endometriosis, we thought this is very close to the uretrovesical junction, and we decided to have a ureteroneocystostomy. You have to open the ritzy space to reduce the tension at the anastomotic site, and this is the transected ureter. It was fish mouth after excising, freshening the edges. We need to make it fish mouth, and before actually doing the anastomosis, a psoas hitch was done to reduce the tension at the anastomotic site. We can use interrupted. This is, I think, 20 vicryl. And at this point, after putting 2 sutures, you put the ureteric stent and the anastomosis is completed. The second layer, the muscularis, is approximated over the ureter, making a small tunnel. Whether it's very essential, it's a debatable topic. But we want to reinforce the suture line and to reduce tension at the anastomosis. The second layer was done with a 3-0 barb suture. I prefer to use smaller 3mm instruments for any smaller, when we use any smaller suture. And the patient made, we did a hysteroscopy and the patient made an uneventful recovery. And to conclude, every gynecologist who is performing advanced surgeries, you should know about the surgical anatomy of complete urinary tract. Already we had a discussion on the bladder injuries and how to prevent them. And anatomical variations do occur, and all of us must be aware of this situation, and you should modify your surgery accordingly. Cystoscopy, although majority of the ureteric injuries are transection injuries, and whenever you are in doubt, if you cannot make any decision, a cystoscopy also confirms that there is no transection of the ureter if you get a good urine jet. And any thermal doubtful injuries, probably ureteric stenting, or if there is a frank damage, definitely a repair. And you can have a urology consultation for your early cases. Even for medical legally, that's a good option. So thank you all for the patient attention. Thank you very much.
Thank you, sir, for your crisp and very, concise presentation. And really, it gives us an insight about the indications for ureterolysis, when to do ureterolysis, whenever we are in doubt of cases, post-operatively also, if you are in doubt, or post-hysterectomy also. And you are highlighted about the severe endometriosis cases. Of course, everybody knows that we have to do that time, and in cases of obliterated periodicity. And you are very correctly told that all these ureteric complications we should diagnose intraoperatively only and correct in the same sittings. Then the patients will have a very less complications and also a less medical legal implications also. So thank you, sir. Thank you for your nice presentation.
Thanks for the excellent presentation, sir. So I think in such cases, like when we have quite a lot of ureteric dissection happening, as in case of parametrial endometriosis, it is always a wise idea to put a drain, isn't it, sir? So because sometimes even the thermal injury, if if it is going to cause some kind of a leak, and if you are going to have some collection, at least we'll have an idea whether, we'll be able to pick it up little early, whether there is a leak or not, by just taking the sample of the drain and looking for the spot creatinine. So that if you are able to identify it early, we can also intervene and, do a stenting or something. A small leak and also can be rectified immediately rather than, leading to a fistula. So in cases like when there is a extensive endometriosis and we are doing quite a lot of dissection on the ureter, I think it is always a wise idea to put a drain so that any untoward injuries can be picked up early by doing a spot creatinine level. And if it is phenomenally elevated, then we know there's some amount of ureteric damage has occurred and there is a collection of urine. But if the value is going to be equivalent to that of our regular blood serum values, then we know there is no injury. So at least it will be giving some kind of a reassurance to us. That
The only problem is how long we can keep.
Yeah, so like only until we have the collection.
So we follow a sonography of the patient the next day, and if there's any evidence of a little hydroureter, we immediately send the patient before sending the This
No, if
way
you are
we
in
have
doubt,
prevented, sir.
obviously we are going to do a CT cysto-urogram and all that. This is the preliminary one. Sometimes, collections can be because of your dissection also. But whether to differentiate whether it is because of the ureteric injury or the bladder injury or just a mere collection, this will help us. So I generally do make sure that I put a drain for all these cases. What do you think, sir?
We
Draining always is beneficial,
putting drain.
definitely.
Pardon?
Because the patient can go home after 2 days and it may manifest, that coagulation injury may manifest after 3 days also. So the drain may not be.
See, I also differ with you, madam. I usually don't take those drain and all, but keep watch. If you are in doubt during that time only, we can explore the ureter.
Not necessary. It has to be the thermal injury. Even by chance, inadvertent injury is there. This will give you an idea. Definitely.
Sometimes they present very late after 7 days and all.
Of course, diathermy injury is going to present only later. The inadvertent injury which has already occurred, we can pick it up early so that we can avoid a major procedure just by simply stenting the ureter. So
that's a good idea. If you are in doubt,
to convey, we need doubt.
definitely you can stent the ureter. If you think there is a blanching over the ureter, doubtful about the viability, then definitely you can.
So I don't know, that one thing I always keep it in mind and I do it for all my routine endometriosis surgeries. Okay, so thank you so much. That was definitely an excellent demonstration. It was a treat to our eyes, sir. So we move on to the next session. Again, a very, very important one, the bowel complications. So we have none other than Dr. Hafiz Rahman, who is going to deal about this and show us some excellent technique and guidance also. So to have in Dr. Hafiz Rahman to be introduced, we have Dr. Dinesh Kansal, madam, who's an eminent endoscopic surgeon from Delhi. Just a moment.
Good evening, everyone. Thanks, Dr. Mala, for making me part of this elite CME today. And we have none other than Dr. Hafiz Rahman. He's been there for most of our workshops, and we all have really relished his surgeries and his discussions. And he's a great teacher, I think teacher of teachers. And we welcome him today on this platform. And we've learned a lot from him. And today he's dealing with, he'll be speaking about a really dreaded complication, which may be fatal to the patient and carries a lot of morbidity. So he will tell us what bowel prep to be done and how to diagnose early, because rather than closing your eyes, it's always better to do early diagnosis. And I think here in a complicated case, the role of drain also is very important. And then how to manage. Over to you, Dr. Hafiz.
Thank you, Dr. Mala and the team Iage for giving me this opportunity. This one. Can you allow the sharing?
Sir, it is already allowed. Just share the screen. Yes, sir.
Okay, done.
Sir, just go to first slide and make it full screen.
Yeah. So today we will be just talking on one of the most dreaded thing for any lab surgeon, and we should actually hope that this one complication should not happen, and if it happens, it should not be missed. I have had actually 3 deaths in my entire career because of intestinal injuries. And this is one of the most
डंपिंग साइट है
situation where you will not be able
पूरे
to
अहमदाबाद का जो
anything
कचरा
for
है
this.
ना वो वहां पे डंप होता है फिर वहां पे जो भी यहाँ का वो कचरा अपने आप जलता
Abhishek,
है
समझ गया, मैंने
can
देखा
you
है
please
वो
mute
बहुत
the other?
बास मारती है
बास
वो।
मारती है जगह वो निष्कलंक की धाम भी वो घोड़े वाला रास्ते में है ना, तो
तो
निष्कलंक की
Can you
धाम पे रुके हुए
mute
हैं
others?
वो।
तो
Abhishek,
वहां पे
वो कल जाने वाला।
अच्छा वो यहाँ पे जो भी मतलब म्युनिसिपल कॉर्पोरेशन में जो
Abhishek,
है
can you please
बंदे
mute the others
उनको
from your
अचानक हुआ कि
perspective?
ये नहीं होना चाहिए तो मतलब डंपिंग साइट मतलब तू सोचे ना लिटरली माउंटेन जैसा है वो।
हाँ मैंने देखा है,
उतना कचरा है
मैंने देखा है।
तो वहां पे
एक
से
मिनट रोल करना।
इन लोगों ने सब कुछ कचरा है ना वो पाउडर फॉर्म कर दिया और
Excuse
उसको
me.
रोड बनाने में वो सब
शायद
इस्तेमाल
बहुत
कर
बड़ा
दिया
सर्कल सर
तो
जैसा है।
पूरा क्लीन कर
Are you able to find out who is
एकदम
talking?
हेलो।
No, it is the chief, the platform provider is a good
नहीं टाइम लगा
This is
Mala,
from the
you can mute him.
Abhishek side
बालों
only.
का कचरा था
Mute him.
No, Abhishek is already.
yes just click in between the screen and click on next
No, that is fine. I have to get
Sorry,
your
sir,
get
please
this
go ahead.
box muted actually.
yes
You
ma'am
can go ahead, sir.
The thing is, this is one of the dreaded complications which we all do not want to have actually. Now, one of the most important thing in this bowel complication is basically how to prevent the injury to the bowel. One of the reasons why we have bowel complications is during trocar injury. During trocar injury, the most important thing with trocar is that do not overshoot the trocar. Most of the time, it's not really the trocar, but you're overshooting of the trocar suddenly, which creates bowel injuries rather than any of the other reasons. It's neither the position nor the whether it's the umbilicus or the upper abdomen. Of course, upper abdomen is much better. So try to see after some time we have been putting always direct hooks. So after some time we get into a stage where we can actually feel each and every layer where the trocar is passing. Because when the trocar passes through each and every layer, you can actually understand the density of that layer. When it passes through the fat, you can see it's fat. When it passes through rectus sheath, you can identify the rectus sheath, peritoneum like that, you can identify. But the most important thing is use a very sharp trocar. Blunt trocars actually, or blunt some sharp trocars actually will facilitate the sudden pushing of the trocar into the abdomen, and that is one of the reasons for these kind of injuries. Another thing is use of vasopressin can actually prevent a lot of bowel injuries, basically because, especially when the bowels are adherent to the uterus or the ovaries, when you inject vasopressin into the uterus and ovary, two things happen. One is the vasopressin will allow these addition. Vasopressin goes into the addition. Wherever there is a defect in the stenosa of the uterus due to additions, the vasopressin goes into that and loosens all those bowel additions. The second thing is when it is an avascular addition, when the additions become avascular, it is much more easier for you to dissect those additions because see, once blood comes, the entire picture and the entire tissue identification goes off. When there is no blood, actually, it is much more easier to identify these additions and go ahead. Then, of course, the use of correct instruments. And another very important thing is whenever you put in the trocar, get a 360-degree vision of the trocar. Understand that you have only the falciform ligament which is attached to the anterior abdominal wall. Rest nothing is attached to the anterior abdominal wall. Falciform ligament with that part of the liver. So when you rotate your telescope 360, you should understand there should not be any resistance to that rotation of your telescope. If at all there is any resistance, understand there is something wrong, and you have to find out what exactly is going wrong. Here, if you can see the addition lysis, here you can see the bowel additions, and you can see how the bowel is adherent. We have injected vasopressin. See, these kind of additions, you should understand two things. One is you keep that bowel under good stretch. The second thing is you should understand that you always use scissor. See, don't cut actually close to the uterus. Most of the biggest problem is you tend to cut very close to the uterus and you get into a layer of the uterus. The moment you get into a layer of the uterus, your plane is lost. So you'll never get into the correct plane. So do not cut very close to the uterus. You can see how the bowel is. See, actually the bowel is here. It is not here actually, the bowel is here. And this is the plane where you have to get. So get into that correct plane, you will find that your dissection is much better. The moment you get into a wrong plane, that is to get into the safety of bowel, which you are not, which you are more scared of, and uterus, which you are not scared of, you find that you will never lose the, you never finish the addition. Can you see that? Here, you should go into that plane where neither you are damaging the uterine musculatures, here you are getting into the muscle of the uterus. Can you see that? So you change that plane. So get into the correct plane, you will find that your addition lysis is much better. And another point is when you get stuck at one area of additions, do not keep going into that exact area, go to some other area, and you will find that the stuck area will get loosened up very easily. See here, since we have gone into the correct plane of addition, you can see the addition lysis is actually much more easier. Now, if you can see here, when you put in the trocar, see here, you can see once you put in the trocars, you have to be careful that you are to see the nice serosal surface. If you see it this way, understand there can be some area of damage. So in those cases, what you have to do is you put in the trocar through some other area and then visualize the bowel here. See here, you can see that the trocar is here. You do the addition lysis always. Do not remove the trocar. Whenever you feel that the trocar has gone into the bowel or there is some problems, do not just have the usual reflex of just removing the trocar. Keep the trocar there, or rather, I would say, push the telescope inside little more if you are exactly inside the bowel, so that you do not miss that area of bowel. Now, after that, you go and dissect this area. You can see here. You can see where the trocar has gone. Can you see that? Many times you will feel that the trocar has gone into the fat, but you have to be very, very careful in doing this dissection and understanding where exactly the trocar has gone. Do not move the trocar at all. The moment you move the trocar, you miss that injury. Can you see that here? You can see where the trocar is gone, and exactly in that area, you will find that there is a small injury of the bowel. See, these kind of injuries, unless you search exactly that area, see, this is the bowel injury here. This can be very, very easily missed unless you exactly look at that area. So this is identifiable only because we didn't remove the trocar immediately. So the usual instinct is that you just remove the trocar immediately, and that is where most of us get into problem to identify the bowel injury. Now, sometimes when you use the morcellators also, you can see what happens here in a morcellator. This is a non-in-bag morcellation. Nowadays, it's all become a in-bag morcellation. So these problems of bowel injury is much lesser. So when you use a morcellator, you can see, you have to see when the uterus rotates. Sometimes what happens is when you do it very fast, the bowel also just comes into with the fibroid. The bowel is attached with the fibroid and it just comes in. And you will find that here you can see what happens with the morcellator here. You're doing the morcellation. See, that is where, see, inadvertently you pick out a small part of the bowel. See that what happens? See, you will not even understand that you have morcellated the bowel. Can you see here? That is where we have morcellated the bowel. Small one, when you see that needle, you should identify that morcellation. The problem comes not when you do the when you have the complication, but when you leave it unidentified. That's what happens in all these kind of patients. So you leave it unidentified, then you had it, and you need to repair it at this stage. Now, another issue is basically the detection of these kind of bowel injuries. This is one of the most important thing again. The bowel injuries has to be detected when you do it, not after you do it. After you do it, it's a different story altogether. So the most important thing, as I said, is that every point you should be able to identify the tissue which you are going to cut. Number one, the tissue which you have already cut. These two things you have to be very clear on at every single point, and you should be able to clearly identify mucosa. For this, one of the most important thing is to have a very good camera and keep your camera clean always. This is the problem when this is the problem which I have with all the smoke which is coming there and all those things when you dissect. Sometimes you fail to identify the look of the mucosa. So we always look at the tissue and identify structure. So that look of the mucosa goes on. Now, once you have, suppose you have a good adhesiolysis and you've taken out the uterus, the bowel is there, the intestines are there, you want to just check the intestines. We do not do this gas test at all, like putting water in the pelvis completely and then pushing gas. It's a very false test to my understanding. The best thing is to do the dye test. Do not put any water. What we do is we put in a Foley's in the rectum. Then you have the Leach Wilkinson cannula on the Foley's, which fits in very well. And you can inject a good amount of dye, at least 400, 500 ml of dye has to be injected. Methylene blue dye has to be injected. And that way you can actually see the bowel leak very easily. Another method is to check with sigmoidoscopy. Sigmoidoscopy is, of course, a good method provided the bowel is well prepared bowel, where you have no fecal matter inside and the bowel is well prepared with the peg leg. Peg leg is one thing which we usually use for preparation of the bowel. And all these cases of small bowel adhesiolysis, it's very important to check the bowel completely from one end to the other. The small bowel has to be checked. The only way to check small bowel is to inspect both sides and slowly go ahead with the 2 grasper technique, where you can slowly walk through the small bowel. That's the only way to check. Not like in a large bowel where you have dye or air or whatever put inside and then do it. Now, you can see here what happens. See, this is the adhesiolysis. This is the patient who had recurrent ovarian abscess, or rather, you can say pelvic abscess, where we are doing the adhesiolysis. As you can see, this is a rare case of rectopelvic fistula, where there is a rectal fistula which is opening into the near the ovarian. Can you see that? See, this looks like fibria, but you should understand this. The look, exactly the look is not really of fibria. This is actually the bowel mucosa and not the fibria. So when you dissect it, you will understand this is a rare case of rectopelvic fistula. It's not, and you can see the abscess, you can see the infection over there. It's not really a feculent infection, but she keeps on getting a recurrent infection in this case. And as you can see here, see that's the ovary, and here you can see the bowel here, and that is where the bowel, we close it. So in these kind of chronic fistulas, it is very important to, it's not like a bowel injury. You can see there is no raw area to classify it as a bowel injury. It's all a formed area. So you need to excise that mucosa which is sprouting out and then only repair the bowel. Same thing like same as a vesicovaginal fistula, where you need to excise the fibrous area and then repair that fistula. Now here you can see another bowel complication which has occurred because of basically because of this is actually a case of dermoid turning into a malignancy. You can see it looks like a dermoid. You can see that it's infiltrating into the bowel. This is not actually a this is coming as an infected dermoid, recurrent infection of dermoid, but there was a malignancy, squamous cell malignancy also in that. You can see that. So these kind of cases occurs usually in 2 types of, not other than malignancy, it can occur in 2 cases. One is ulcerative colitis, where you have this kind of diverticuli, or in tuberculosis. These are the 2 cases where you can have a permanent fistula between the ovarian cyst and the bowel, again, where you can have multiple abscesses of the ovarian cyst. Here you can see the hair and all inside, and you can clearly see the fistula here. This is the fistula here. See that? That's the fistula area. So you can dissect it completely and then excise the edges and then close it. These are important things to understand. It can be classified as a complication, but it's not really a complication. It's actually a part of the disease. You can see the mucosa, bowel mucosa, very nicely here. Can you see that? This is opening right into the ovaries. Can you see that? So this is not actually an injury. You can see the mucosa formed around it. So you have to excise this mucosa completely and then do the repair of these kind of fistula. Post-operative identification of these kind of bowel injuries is extremely important, and the most important thing is the pulse rate. In our unit, whenever the patient's pulse rate is higher, there is an alarm which is created. Pulse rate constantly higher than 100. Always we create an alarm, and immediately we have the two people coming in. One is the echo technician will come in, of course, with the cardiologist also to rule out pulmonary embolism. The other one is the gastroenterologist or our gynecologist will come in to rule out any bowel complication. Understand that this pulse rate increase in bowel injuries or any visceral injuries is not because of any infection or anything, but whenever a viscera is open, like a vessel is open, pulse rate doesn't increase because of hypotension. Pulse rate increases immediately after the vessel is open because of the neurotransmitters which are there. This happens with every viscera. When bladder is open, bowel is open, pulse rate increases. These are because of the neurotransmitters which are there and not because of infection. And you can see that when you just clamp the vessel itself, the pulse rate will come down immediately. So these are mechanisms by which you can identify this kind of problem. So look at the pulse rate always, immediate post-op, first day, second day, all this time. Pulse rate is one of the most important things. Do not get carried away by flatters and passing of motion. To my knowledge or to my understanding, these things doesn't have much role in identifying. Flatters pass doesn't mean that there is no bowel injury. Motion pass doesn't mean that there is no bowel injury at all. So whenever you have a doubt on these kind of things, feel of the abdomen is very, very important. When you try to understand the feel of the abdomen, if I put my hands on the abdomen, I immediately understand there is some bowel complication. So it's very difficult to explain what is the feel of abdomen, but you can get into that mode of understanding the feel of abdomen to understand bowel complication, especially paralytic ileus and bowel injuries. Now, ultrasound is a good method which you can do immediately. On ultrasound, the most important or the only thing what you see is basically there will be a lot of fluid outside the bowel or in the peritoneal cavity. If you see in our cases, we do not wash the peritoneal cavity at all. In any case, we just suck out the blood because of obvious reasons to prevent adhesions, because washing, I believe, can produce more adhesions. So there will not be any fluid in the abdominal cavity in our cases. So if at all post-operatively we find fluid in the epitomeal area, especially the liver is covered with fluid spaces, then definitely we suspect a bowel injury. CT scan screening is one of the most important things. Putting the dye through the rectum as well as the oral dye and screen the patient, and this will help understanding exactly where the bowel injury is. Another thing is in cases of paralytic illness where you have a distended abdomen, when you put in the dye through the mouth and for small bowel screening and all, you find that most of these cases the paralytic ileus goes on. The dye actually stimulates the movement of the bowel, and actually the paralytic ileus goes off in this kind of cases. Now, intraoperative detection, again, it's very important to detect intraoperatively these bowel injuries, and it's very easy to manage these bowel injuries when detected intraoperatively. You can see here how the suturing of the bowel is done. Nowadays, we almost always suture. It's a little old video. We almost always suture with only the barb sutures, which is very, very useful for these kind of bowel injuries, and no interlocking sutures are taken nowadays, just the barb sutures, and you can see that the wounds heal much better than the usual vital sutures, because of the obvious reason that it is much more, the tension between the suture lines is much better. When you suture the bowel, one of the most important thing you should understand is you have to take the exact distance between the two sutures in both sides. If you have a distance disparity between both sides, like one side you are taking 1 centimeter, the other side you are taking half a centimeter, now those are the reasons for leaking. This is very important. This is a very important factor which you have to see in this kind of suturing. And bowel always is sutured with double layer and phenomenal patch in those cases. Here you can see another case of bowel adhesion and formation of subacute obstruction with a paralytic chest kind of picture you can find in this case where it is due to bar suture. Bar sutures are in literature we have some cases of bar sutures having this kind of obstruction and paralytic or bowel obstruction, but in reality it's a very rare phenomenon. We just had one case, that's why we are showing it, but in reality it's an extremely rare phenomenon. Sometimes you get cases like this where you have the gauze piece which is forgotten or foreign body which is forgotten inside. This foreign body always, like mesh, same like mesh, foreign body always have a capacity, especially in cases of when it is forgotten in places where there is a lot of additional life being done, it has a capacity to erode into the bowel in such cases. You can see it's like a gauzy bioma, you can see the gauze piece there, and you can see how it is eroded into these kind of things should not happen. It's very important that this should not happen in any of your cases. And if these kind of things happen, usually the treatment would be to do a closure of the wound, of course, but always combined with the diversion of the bowel, that is a colostomy or an ileostomy. It's very, very important to have a diversion in these kind of secondary bowel injuries. Now, mixed bowel injuries like this, we can classify it into extraperitoneal and intraperitoneal. Extraperitoneal bowel injuries, which usually occurs in cases of rectovaginal endometriosis deep inside the inside the pelvis, or when you do vaginal surgeries, especially when you do the sacrospinous fixation. Those are very easy to repair and nothing happens usually. Because the bowel injury externally also this is getting closed, but intraperitoneal bowel injuries are the ones which you have to be careful, where the bowel is exposed to the free area of the intraperitoneal internal part of the peritoneum, and these are the ones which can actually leak. Mostly I've seen with small bowel, because we do a lot of ideal vaginoplasties where you have the anastomosis of the bowel. Mostly the leak occurs on the 5th day. So watch the patient until the 5th day. Even though postoperatively we start oral liquids on the after 24 hours nowadays, because staplers, there is no issue of starting oral liquids after 24 hours. Even in extraperitoneal bowel injuries also, we do not keep them nil orally at all. I think gone are those days when nil orally is kept for these kind of bowel injuries. You can start the patient on oral fluids after 24 hours, but understand that the leak can always occur on the 5th day or the 1st day. This is very important in cases of bowel injury. Here you can see a case of rectovaginal fistula completely closed. Now, fistula is actually an escape. When a fistula occurs, you should pray to God that you have escaped from a severe complication, which can be a peritoneal fecal peritonitis. Fecal peritonitis is one of the most difficult thing to manage, because this becomes a multi-organ failure and it has to be managed in a very good ICU. Because that's where we have lost patients, even though we have a fantastic ICU here with entire setup in our hospital, but still this can be a complicated issue when you have a fecal peritonitis. So whenever fistula occurs, it's actually an escape for the patient. As you can see here, you can see clearly that's a fistula. It's a posterior fistula. This was a case where there is a lot of sacral endometriosis which we have resected, and you can see it's fully posterior to the rectum here, and not at all anterior. So it's a little difficult to repair. You can see we are injecting the methylene blue. You can see the methylene blue coming here. And these cases repair it nicely and do a colostomy, which is very, very important to do a diversion colostomy in all cases of diversion colostomy or ileostomy, all cases of secondary repair of bowel. Extremely important to understand that. Now, sometimes you again find out these kind of cases where you have the entire mop which is sitting inside the abdomen. This was a case which was referred to us with a pelvic mass. 1 month after the cesarean hysterectomy with a mass in the abdomen, when we went in, this was the picture which we got. Here you can see the entire mop which is there, not like first piece or anything, the full mop. I think some people have kept a full bedsheet also inside. So this is an entire mop. But understand this long-standing mops, you have to be very, very careful. This patient, we had to resect almost half a meter of small intestine because these patients, when there is a mop, you'll find that multiple seal-like perforations can occur in the bowel if it is a long-standing mop. It's not about just taking out the mop. See, taking out the mop will be easier. You can see that you can pull it out. See that like that. See, once you pull it out, it comes out very nicely. It may not look like bowel injury at all, especially in the small bowel. It is extremely difficult to understand these injuries, so we have to be very, very careful in taking it out. Not only taking it out, understand that you have to seriously look into the small bowel injuries. If you find small bowel injuries in these cases, it will be by one of the cases where I would prefer to do a laparotomy and resect that small bowel completely wherever it is stuck. Otherwise, two things, you can have fungal peritonitis as well as multiple small bowel perforations. So it's not a very easy thing. It's very easy to take it out. It may look like there is no perforation, but it can create a lot of complications. So thank you so much for your patience.
So great collection of cases, phenomenally wonderful presentation, sir. It was an eye opener.
And like you, we got few very important tips. One was while with trocar injury, we all know we should keep the trocar there, but like when it is still hanging at some place, that's the best time to repair. And later on, you can complete the adhesive lysis. And the small bowel injury is has to be traced by walking over it, same as onco people do. That's the only way, otherwise you can easily miss it. And always a colostomy for secondary bowel repair. That was a great tip you gave us. And there cannot be any shortcut for that. And for primary repair also, some people talk about if it's a low repair, then you must do colostomy. If it's a high repair, you can. So that's not the.
Actually, what my experience is completely different. Basically, because low repair, what you are talking about is this is where you have a low repair. So in those kind of low repair, it's extraperitoneal bowel. Extraperitoneal bowel means you have the vagina, the outside part of the bowel is closed even otherwise. It gets adherent. So chances of leak are much lesser in an extraperitoneal bowel. Only thing is, if it is very close to the sphincter, where the pressure is much higher in a very low repair, which we usually do not have that kind of a low one. Because the gastrosurgeons, they have a low resection. In those cases, the chances of leak is very high because at the sphincter level, the pressure is quite high. That is why they do the diversion colostomy. But in our cases, it is not that low. So absolutely no need of a diversion colostomy in cases of primary bowel injury. Secondary, always do a diversion.
Great. And we love that you started using only bath suture because bath had become a norm for bladder repair, but
Yes,
bowel we were
very
still
much.
for vital. And do you use a two-layer suturing for bowel always?
Always. Always bowel we use two-layer suturing. We never venture into one layer, even though bladder we have started venturing into one layer. Bowel two-layer, I don't want to take any risk on bowel injuries because this is one of the dreaded things which I always had, two layers with an orbital.
I think even for small bowel, two-layer repair is done.
Yes, yes. And do not suture, do vertical suturing. When you do two-layer vertical suturing, what happens is there is a stenosis kind of thing. The lumen will reduce. So try to do a horizontal suturing so that the lumen actually increases.
So
Thank you so much. Great presentation.
How about bowel preparations? All these patients where your bowels
We do not nowadays do much of bowel preparations because unless in infected patients, there is no need of giving 3 days liquids, antibiotics, all those things are gone. Just give a peg leg if at all you are planning for any bowel resection or things like that. The bowel has to be empty. There should not be fecal matter in the bowel. That's the only thing. So give a peg leg and ask them to have a good bowel movement before the surgery. This
We
is the
have
most
Dr.
important.
Sanjay Patel
No
also
need of
here.
antibiotic. Huh?
Dr. Sanjay Patel is there who never gives Peglac or Actilite.
Yeah, we give Peglac basically because we wanted the bowel to be empty. Otherwise, if fecal matter keeps coming out, then it becomes more difficult to repair. If the bowel is empty and clean, it's much more easier to repair.
Thanks a lot.
Excellent presentation, Abhi sir.
Thank you, Pandit.
Sir, in which cases you will advise divergent colostomy?
Mostly diversion colostomy we do in secondary bowel injuries, not in primary bowel injury. Rather, I would say a missed bowel injury. The other cases where we do diversion colostomy is where there is a primary bowel pathology and you have a bowel injury. See, like ulcerative colitis, tuberculosis, or in cases like we have shown that there is a malignancy infiltrating into it. Those kind of cases I prefer to do a diversion colostomy. Otherwise, primary bowel, simple bowel injuries, absolutely no need of a diversion colostomy.
Yeah, nowadays the incidence of divergent colostomy is almost very minimal. Most are repaired by primary closure.
But do not try to manage a secondary bowel injury without colostomy. We have managed. In the cases which you saw that rectal fistula and all, actually we didn't do a diversion colostomy in those cases. You can manage sometimes, but 50% of them can go into leak if you do not do a diversion, and that leak can be very, very dangerous because already the patient is in a compromised situation with septicemia infection. Another leak the patient may not stand.
So in one of your video, there was some bowel contamination and still you had done a primary closure. Is that all right, sir?
No, that is not primary closure. We have done a closure, plus you're doing a diversion. Right? See, closure has to be done for all cases. You cannot keep it open and just do only diversion. You close the bowel and then do a primary diversion. Closure has to be done. Closure is a must.
Okay, right, fine. So this paralytic ileus, you were suggesting that you are going to only inject some dye and then the paralytic ileus.
Paralytic ileus, see all these cases of bowel problems, that distended abdomen. It may be paralytic ileus bowel injury. When you do an oral dye, with for a CT scan, or send it for a CT scan, they will ask them to drink that oral dye. This oral dye itself is a stimulant. So what happens is after they come from the CT scan, they will have pass motion very nicely and patient will be absolutely comfortable if it is a paralytic ileus because it stimulates the bowel and it works very well.
Yeah, same thing as GST people do. They say the dye is a good stimulant for the bowel.
Yes.
So it may be diagnostic as well as therapeutic sometimes.
Therapeutic, yes.
So simultaneously, we also have to check the electrolytes to see whether there is any hypokalemia because most of the times the hypokalemia will cause so much of paralytic ileus.
In paralytic ileus.
Yeah.
Yeah, immediate post-op, very less chance of hypokalemia as such. Immediate post-op, very rarely. Mostly paralytic ileus. Mostly these patients are not really paralytic ileus. There may be subacute obstructions. And these subacute obstructions also get cleared with the dye. When the contraction occurs in forcibly, the small additions can go away and subacute obstructions can get cleared.
So many times these paralytic ileus patients, they ooze out quite a lot of fluid into the abdominal cavity. So in such cases, like we have seen, sir, like when you put a drain, these paralytic ileus patients will have lots of fluid secreting. So if you correct the hypokalemia, automatically everything subsides. The fluid also secretion subsides, the bowel becomes very soft and it starts moving. We don't have to do anything.
But usually, see, our center, the differentiation criteria between paralytic ileus and bowel injury is presence of fluid in the outside space, outside the bowel. If you have presence of lot of fluid outside the bowel, mostly we go in for a diagnosis of bowel injury. If there is no presence of fluid outside the bowel and there is fluid levels inside the bowel, then it could be paralytic ileus. That's how we differentiate. Mostly it doesn't secrete that kind of fluid. Only in cases of toxic megacolon or this mesenteric vessel thrombosis, which is an extremely dreaded complication. I have two videos of one mesenteric vessel thrombosis and one toxic megacolon. These are extremely dreaded complications where you have no bowel injury but a lot of fluid in the peritoneal cavity. That is bowel necrosis basically. Bowel necrosis can occur. That is where you have a lot of fluid in the peritoneal cavity, where you have to resect the entire vascular segment of bowel.
Okay, so I think it was a very, very interesting one with lots of take-home messages. So thank you so much, sir, for that excellent presentations, and thank you so much, Dinesh Kansal madam, also for moderating very well. So we move on to the next topic, which is again a very, very interesting and challenging topic. It is on vascular catastrophe. So unlike other complications where we have some time to literally, make sure that we have help and we get the problem rectified. In this kind of a situation, we are in a fix because it is like a time bomb which is clicking, and then unless and until you act immediately and take care of the issues, the patient is going to sink. So here we have Dr. Sanjay Patel to show us how to tackle such a situation, for which we have Dr. Aruna Tantia madam to chair the session. Of course, madam is a very renowned endoscopic surgeon from Kolkata, very keen on academics and also interested in training. She's also a robotic surgeon apart from an endoscopic surgeon. So over to Aruna Tandia madam to introduce Sanjay Patel sir and take over the session, please.
Thank you, Mala. Thank you, Iage, for giving this opportunity to be a part of this program. And today we have a very important person, a very eminent endosurgeon, Dr. Sanjay Patel, whom I got the honor to introduce. Dr. Sanjay Patel, as we all know, that he's the director of Mayflower Nursing Women's Hospital in Ahmedabad, and he's a gynec oncologist, having done about more than 50,000 cases of endoscopy. First to be doing the radical hysterectomy way back in 1997. He has done resection anastomosis of the bowel for endometriosis. He's been a pioneer for that. He has got trained more than 1,000 students in endoscopy who are following his teaching all over India. And he has done, to his credit, many live workshops, even in India and abroad, and in numerous awards. Not from Foxy Corion in 2007 and 2019 Shivli Rudra Award, as well as Damayanti Ganatra Award and Ascalap Golden Award, as well as Platinum Telescopic Award. So there's, the list is endless. If I have to go, I'll keep on going on and on. So he's a very simple-hearted person, and we present before you Dr. Sanjay Patel, one and only Sir Dr. Sanjay Patel, who is going to be talking to us about the vascular catastrophe, the complication we all dread. We all know that less than 1% of the cases have vascular complication, but if it is so, it is 100% for that patient, and we should ensure that we do not have, and all the precautions, etc., and how to tackle them is what we are going to hear from Dr. Sanjay Patel. Welcome, Dr. Sanjay Patel.
Thank you, madam, for the kind words. First, I would like to thanks to the Dr. Malaraj and my dear friend Dr. Pandit Palaskar. He is president of the Iage and entire Iage team to giving me this opportunity. Also, Dr. Prabha, Dr. Dinesh Kansal, all the dear friend. I think laparoscopic vascular surgery is really nightmare for the surgeon. And yes, specifically the major vessel injuries really create the big problem. I saw some of the cases and how we tackle it, how we manage it. This is the case, I think. We don't want to discuss later how we introduce the trocar and everything, but this is the one of the diagram. And you increase the pressure, I think the incidence is late. But I think I explained that this is a very simple case of primary infertility, was posted for diagnostic, histero and laparoscopy. And it's a simple endoscopy. That's why we not cross-match. No blood kept the ready. And this is the era for the COVID, during the time of COVID period. And look here, one of my fellows put the trocar, and immediately we recognize that. My anesthetist is telling, Sanjay, it's a catastrophe. And immediately the BP is falling down up to the 50. The entire abdomen is full of with the blood. I immediately rush inside the OT. First, I try to make the suck out all the bloods, because we couldn't know that where exactly injury. So very important part, I think, first we try to identify the injury site. It's also the challenging, particularly in such kind of the cases. Then we look here. This is the huge hematoma above the level of symphysis pubis, and also it's extended. Without a wasting of time, the most important part, then you realize such kind of even though you dissect the aorta during the time of para-aortic dissections, and if injure the vena cava or aorta, the story related to suturing and related to managing this vascular injury is easy. But true cut diamond trocar injury is really create the big problem, because it's really challenging to how manage it. I think without wasting of any time, we immediately open it, because there is no blood is available. We try to make the explore it, and immediately we press with the gauze piece. The first important, never jump to immediately open the peritoneum, because peritoneum over this hematoma, it's the guarded. It's really work as a tampon. And never, we try to make the look properly. We press for the couple of minutes, we look. Meanwhile, everything we try to make the system be stabilized. At that time, we call to the vascular surgeon, but due to the COVID, I think no one can come to help us. And immediately we proceed for the explore this case. Again, the most important part, the proper exposure. Such kind of the cases, never think for the cosmetologically. Proper exposure of the particular space. And look here, we realize that this is the stony hard tissue, because it's we try to make the open the peritoneum with the pure cutting monopolar current. And we try to make the palpate the vessels. But due to this large hematoma, it couldn't possible. Then we try to make the split the hematoma. And due to this high pressure, this is the aortic injury, the multiple sinus tract is developed inside. And it's give the false image at the site of the injury. So at that time, we feel that might be this one is the injury site. We try to make the palpate it. We explore it. Again, we dissect furthermore. And we feel that might be this is the site of the injury. We suture. Never try to, whenever such kind of the hematoma, never use the 50 or 60 prolene. Better use the bigger one. And look here, this is the looks like the sputter, but this is the false track. It's due to the pressure effect of the aorta, it's create the false track. We took the big sutures and big needle. We try to make the manage somehow this sputter. But we realize that this is not the right site of the injury. So first our BG came to control this bleeding. We took the figure of a stitches. This is really wonderful, particularly for the vascular injury. Again, further we try to take the another stitches. And we control the bleeding. This is the big hematoma. Further, there is some of the landmark we follow, particularly in such kind of injury, because here this is the true cut diamond injury. So I think we try to identify the mesenteric vessels, and we try to mobilize the colon, and further we get the more exposure. We also try to dissect the common iliac vessels, but due to the huge hematoma, it's very difficult to identify properly. We dissect furthermore hematoma and we excise it. You look it, it's more than 1.5 inch size of the hematoma. So we properly excise the hematoma. And we realize that due to this pressure effect and due to this fibrofatty tissue is different over this aorta, it's the stony heart. Also, we check the mesenteric vessels, inferior mesenteric vessels. And this is the laterally is the mesenteric vessels. So this is the one of the landmark. And medial to the mesenteric vessels, this is the aorta and inferior vena cava. Further, we try to make the palpate with the finger. We dissect more. And now you look here. So we dissect furthermore. We also check with the finger. The small things is very important and might be benefited whenever you encounter this vascular injury, major vessels injury. But the one of the things we realize that in the major vessels, whenever even the hematoma is formed, any bulging is happen. This is the site of the injury. Look here, now you find out the bulging, and this is the true, real site of the injury. This is the diamond cut injury. So we take the figure of 8 stitches with the proline 20. We not skeletonize the vessels. So even though we have all the vascular clamp and everything, but once you not naked the vessels, you never apply the vascular clamp over it. And knife injury, it's easily you, I think, suture it and usually manage it. But true cut diamond injury, it's very difficult to even though manage with the suturing. So further we try to make the inspect properly. Yet we not skeletonize the vessels properly. We do the blunt and sharp dissections with the finger. We are interested to exactly, we try to make the dissect properly the aorta and then we suture it. But it's next to the impossible in this case. This is mesenteric vessels. And literally, we suspecting that this is the area of the site of the injury. Again, we secure with the sutures. And also we encounter the bleeding. But somehow we manage it. Then we press for the half an hour. We wait. Because we check it. It's any leakage or further expansion of the hematoma. Then we remove it. We find out that everything is in control. We put the snow gel over it. And at that time, we are happy to manage this vascular true cut diamond trocar injury. We put the snow gel and we put the big drain. And abdomen we lower with the suture, with the layer by layer. Patient is absolutely fine during the time of postoperative. The most important part is the counseling with the patient. I think we do the lot of dialogue baji with the patient relatives because patient relatives is very panic. But we explain that some cases, I think it maybe happen. We try our level best. If we not do the any try, patient is die on the table. So I think on the third or fourth day, again we counsel with the patient relatives. And we explain that this is the diamond shape injury. Might be there is a ample of chances of the pseudoaneurysms. So this is not the end of the story. The story is now begun. Patient is absolutely uneventful post-operatively, and we go for the CT contrast, CT angio on the day 5th. And we find out this is the pseudoaneurysms. It's also that we, at that time, everything is with control. We took the cardiothoracic surgeon support, vascular surgeon support. At that time, everything in control, the lot of fibrosis over it. We remove the entire fibrosis over it. We clamp the aorta, and also we secure both the common iliac artery. There is another way to put the balloon, non-invasive procedure, but this is the injury at the site of the bifurcation of the aorta. So I think it's not possible to keep the balloon. So we decided to go for the open. We hyperionize this patient. This is the side. We old suture, and we secure both the common iliac artery and aorta. There is a lot of collateral circulations for the aorta from the vertebral artery. This is the patient right side common iliac, this is left side. And then we identify the pseudoaneurysm. Look here, this is the bulging. We excise the pseudoaneurysm sac. If you skeletonize the vessels, ideally you suture with the 6-0 proline with the Teflon. Without Teflon, the tearing of the tissue is happen. So I think whenever because due to the pulsatile nature of the aorta, high pulse pressure, I think whatever you take the suture, it's lose it. So always prefer to use the Teflon. Even though we apply the clamp at the site of the aorta, the lateral collateral circulations surrounding to the aorta is so high, so its bleeding is happen. Then we prefer to use the 6-0 proline with the Teflon. And we suture properly. Because Teflon is work as a guard. And whatever the pulsatile pressure of this transmission of the aorta, it's guard with this Teflon. So tearing of this particular suture line is very less. So it's very important to use the Teflon for the large vessels. This patient is absolutely uneventful, and she carried the pregnancy naturally, and we deliver at our institutes. During this time, we also encountered the small bowel injury. We manage it, but patient is absolutely uneventful, even the post-operative time. So we remove the 1-by-1 clamp. And look here, we create the plate of the Teflon over this aorta. This is all the fibrotic tissue, we remove it. Mala, the time is over.
You can take another 5 minutes, sir.
Okay. This is another case I think I demonstrated in Dr. Prakash Trivedi event. This is the case of the DI, also involvement of the ureter, parametrium also involvement associated with the colorectal nodules, and also this big nodules near to the internal iliac vein. And look here, just below to this ureter, we find out this is the entire parametrium is involved with the disease. This is the disease surrounding to the ureter. We also excise it. And we do the de-roofing of the ureter because the parametrium is involved. And this is the entire, and at that time, during the time of, because it's densely adherent with the vessels, always we jump for the apply the bipolar. This is the big mistake we done, all the gynecologists. Try to make the catch it because it's the box type of the internal iliac artery. And even though we not skeletonized properly due to this disease, so we took the figure of 8 with the number 1 victory. Look here, this is not small needle because always in such kind of cases, better to take the large needle. Because internal iliac vein sometimes is more than 1 inch size and it's a box type. So we manage it and we lively demonstrated during the time of this AGL workshop. But at that time, the most important part, the presence of mind and patience. So now this is the end, and you look it properly. We excise the entire disease parallel to the internal iliac vein, and we keep the drain, and we came out. This is another case of, I think what we feel that sometimes it's a really nightmare, small vessels. This is the epigastric vessels injury. And just we try to make the catch it. We fulgurate it. In the such vessels, I think it's fail it because suddenly it's developed the hematoma. And we couldn't identify the site of the injury. We prefer to take the stitch on both the sides, but still the hematoma is increased. So we dissected the origin of the epigastric vessels from the external iliac artery, and we apply the clip over it. Look here. And now we feel that we secure this bleeder point. So we apply the clip and we manage. So vascular injury is always it's the nightmare for the surgeon. Thank you, Mala. Thank you, Madam Dr. Aruna.
Thank you, sir, for excellently showing the presence of mind and dealing with such complication. I think so everybody's heart really miss a beat only, and one is not able to think straight. But you kept your cool and you managed the injury so very well. That is really commendable. And the best thing that you converted it immediately was a brilliant move, because you didn't have blood in hand, and if when you see blood all over, I think so one should not have any doubt of converting or any.
Madam, suppose I do the para-aortic dissections, and if I dissect the vessels, and suppose inferior vena cava injuries happen, definitely I try to make them managed laparoscopically. But pulse pressure is so high with the aorta, and even though it's a diamond cut injury, never waste the time. Yes. If you waste the 5 minutes, I think it's the end of this case.
Lose the patient. You can lose the patient. And also you have shown very excellently shown how to repair, manage the epigastric vessel injury, which definitely is a nightmare for many. We all have come across such injuries in our, no endoscopist can say that yes, we have not done any injury. There, bigger or small vessel, one has already done an injury. So the risk factors, basically, as we all know, it's in a very thin patient, there's a great chances of injury by the trocar or the veris, or also in a patient where you have at the level of the aorta, which is there just below the at the umbilicus, just below it. So in a thin and a very obese patient, there's always a risk of injury to such, and one should keep all that in mind when we are dealing with direct trocar as well as veins. So thank you for an excellent presentation, Dr. Patel. And it's always a pleasure to learn so much from you.
Thank you, ma'am.
Thank you so much.
Sanjay sir, it was a brilliant and marvelous presentation. Everybody is in love with this presentation, you know.
Brilliant.
How sir has filmed it.
I'm sure every gynecologist will be praying that they don't end up in such a situation. You should have a really a lion's heart to tackle such a situation, and to successfully, you have also given her a baby. I think that lady has a very strong life. So she has overcome all the hurdles and has also been gifted with a baby, so something phenomenal. There is some strong lifeline for her, sir. I think it's efficiently managed, and it was a real eye-opener for all of us, sir. Thank you so much for demonstrating. And hats off to your IT team. In such a scenario, they had covered the entire scenario so beautifully, which is definitely not possible in any other center. I can
This
definitely
is the first
share that.
documentary clipping. It's the trocar injury. Somebody open the vessels and injure it, it's a different story. But somebody do the direct trocar inside. And I think this is the first of its kind in the world. And it's the story of survival. Out of 1,000, 999% diamond trocar injury patient is died.
Yeah, so the situation like this, when your entire team is really working to save the patient, your IT team also is efficiently capturing the entire video, sir, which is phenomenal. Thank you so much for sharing it with us, sir. And
main problem related how you counsel with the patient relatives.
Exactly.
The situation outside the OT is the different. We are on the such a trace at that time, but I think we have to have the do it something for the patient.
Exactly. The very fact that she has come back to you after all this for a delivery and all that itself talks so much about your management and your efficiency, sir. Hats off to you, sir. It's simply mind-blowing. So thank you so much. We move on now to the next session.
Mala, 1 minute. Mala, 1 minute. Sanjay sir, your single message to all our gynecologists, whenever you land in such complication, what step we should follow immediately till the cardiovascular surgeon arrives?
I think if you wait for the cardiovascular surgeon, at that time patient is dying. Because any major vessels, even the external iliac vessels, or even the aorta, the pulse pressure is so high. You have to have the first, you put the pressure effect. The most important part, never open the peritoneum. Very important part about this hematoma. Second important, first you open, expose properly, large incisions of the abdomen and press it for the couple. And meanwhile, the anesthetist team take care for the stabilize the patient. And second, if somebody is, I think, preparing for the blood and everything. But I think COVID era, I think after 1.5 hours later on, we get the one bottle blood.
Yes, so my husband, who's a surgeon, also shared his experience of injuring the aorta, where he was working in one of the hospital and one of the residents put in a trocar and there was blood all around. When he went and opened up the abdomen, there was a tear in the abdominal aorta. Put his finger inside the abdominal aorta, asked the cardiothoracic surgeon who was working on an open CABG in the next theater. He said, I cannot come until I finish that. So for about 1 hour, they sat down with the finger inside the aorta while they are managing the rest of the thing, getting the instrument, getting everything, arranging blood. and then the cardiovascular surgeon came and then
Best part,
so
any
this is
hematoma,
important,
madam,
pressing upon the
pressing the hematoma. If the exposure is happen and you injure the aorta, at the time use the finger and press with the finger. Always just control it. Whether it's the inferior vena cava or aorta, just you put the press with the finger. Majority time it stop the bleeding.
Thank you
Thank you so much, sir. Thank you so much.
Thank you.
Thank you, Aruna madam, for sharing that experience.
yeah. It is not every day that we get to at least, but we should learn from other people's experience.
Yeah.
Right,
Thank you so much, sir, and thank you, Aruna madam, for moderating this session so beautifully. So we move on to the final talk for the day. Of course, we have seen all the intraoperative complications. Now we come to the postoperative complications, which is again a very important factor to make sure our patients go home safe. So the most important topic, deep vein thrombosis, which again is one of a condition which can be preventable, but if ignored is a catastrophe. So to throw more light on this, we have Dr. Priya Bhave to talk on this important topic, and we have Dr. Tamilarasi to chair this session. So Dr. Priya Bhave, over to you. And Dr. Tamilarasi is a endoscopic surgeon from Chennai, and also she's very keen in high risk obstetrics. And may I request Dr. Tamilarasi to introduce Dr. Priya Bhave, please? Please unmute Dr. Tamil.
Thank you, ma'am. First of all, I thank Dr. Malaraj, ma'am, and the Iage team for giving me the wonderful opportunity.
Tamil ma'am, may I, you might be logging from two devices. Just mute one device.
One second. Is it okay now?
Yeah. Ma'am, actually it's echo.
Okay. Dr. Priya Bhave, she is the consultant and head of Department of Reproductive Medicine from Bansal Hospital, Bhopal, and she is the F&B reproductive teacher and an ex-faculty DM reproductive medicine. More so, she is a FOGSI recognized trained in basic and advanced fertility management courses, and Cochrane reviewer and author, the secretary of MP chapter Indian Fertility Society, and an executive member of IAGE and an Ironman triathlete. Over to you, ma'am, Dr. Priya Bhave.
Thank you so much, Doctor, for this nice introduction. And I would like to thank Dr. Mala for inviting me for this very interesting webinar.
Next week.
Mute. Yeah.
Gujarat team ma bahut question aave
For Abhishek, please.
Yeah. So I'll just start sharing my presentation. It is a wonderful event that you have put together, Mala. I'm really enjoying it thoroughly and remembering all the complications that I have encountered and done over the last 12 years. So I'll be talking about deep vein thrombosis, and I think it's very important that all of us be aware of this, because most of the times all of us will see this once or twice in a lifetime. I saw my only case of deep vein thrombosis around 3 years ago. We did a large dermoid cyst. The patient went home, and surprisingly, she had swelling in one of her legs, but she never correlated it with the surgery because it happened around 4 days after she was discharged. Luckily, one of her relatives used to work in a hospital, and she casually mentioned it to me in the lift, and I immediately raised an alarm and called her, and it was a big DVT, which was eventually managed. This led us to looking at the guidelines and looking at all the risk scoring eventually. And now I'll eventually tell you in the presentation that we are using a prophylaxis for almost all the patients who undergo operative laparoscopy. Now, we know that this long-standing varicose triad, the triad of stasis, of vascular injury and hypercoagulability, when it comes together, and that's what results in a clot, and this clot can travel and lead to an embolism. So the mnemonic that we use is stop clot. So stop is the signs and symptoms: swelling in the leg, tenderness, out of breath, or the patient passing out, and chest pain, leg discoloration, tachycardia. And then when you are at O, it's time to call for help. That is to immediately start managing the patient. Now, when it comes to gynec surgery, women are actually at a higher risk of thrombosis, and almost all the pelvic surgeries, abdominal surgeries are at a higher risk of DVT compared to the limb surgeries or other surgeries, and the incidence is anywhere between 11 to 29%. But now most of us are doing surgeries laparoscopically, and after laparoscopy, the incidence is not as less as we would like to believe. It's still 7%. So maybe 1 in 12 or 1 in 13 patients will have a DVT, which is a big number. Now, when the patient already has a DVT, how to actually diagnose a DVT? Because my presentation is not only the prevention, but also the management. So very well laid out criteria, Wells criteria for DVT. I think all of us should have it on our tables and should teach it to our residents. So a score of 0 to 2 is low risk for DVT, 1 to 2 is moderate risk, and more than 3 is high risk. So when the patient presents with a swollen leg, when one calf is more swollen compared to the other, and this patient either has a malignancy or immobility or all these other symptoms, that's how the points are assigned. And what we do is immediately carry out an ultrasound. If we see a clot, then immediately we have to give the therapeutic dose of anticoagulants, of which we have many varieties, and we'll discuss that subsequently. Now, the question is whether laparoscopic surgery is at a lesser risk of DVT compared to open surgery, and should we really bother? So this very, very large series of, more than 1 lakh patients, what they found is, compared when you do a laparoscopic surgery, there is a almost half the prevalence. So the odds ratio for VT in open procedures is 1.8. So an open surgery patient can experience double the DVT compared to a laparoscopic one. Now, there's a meta-analysis on laparoscopic versus open, and they said that probably a chemo prophylaxis for VT is unnecessary for a lap chole compared to a open surgery, because we feel that the gynec laparoscopic surgery is smaller incisions, less blood loss, faster recovery. So the patient is ambulatory faster. But we actually need more studies, and this is actually a very good article from the BMC, which said that a series of 355 patients post-op DVT was almost 11.55%. So this will also depend on your case load and what kind of cases you are doing, what is the age group, what are the pre-existing factors, and also the complexity of the surgeries. What is happening is that now many surgeries are being carried out in onco patients, many surgeries are being carried out in obese patients, in pre-existing medical disorders. And if you look at the risk factors, the main risk factors of DVT in patients with gynec lap surgery are if the surgery is longer than 1 hour. And most of our surgeries compared to open surgeries will be longer. Then intraoperative pneumoperitoneum, if it exceeds more than 15, that also puts the patient at higher risk of DVT. And if the patient is in bed longer than 3 days, that also increases the risk. So if you are doing a laparoscopic surgery, which is more than 1 hour, if you're keeping the intraperitoneal pressure higher than 15, or if the patient is in bed for longer, this puts her at a higher risk of DVT. So how to prevent and how to manage? So we look at the society guidelines. We have the ACCP guidelines, the SAGES guideline, and the ACOG guidelines. Now, what is very important is I think all of us should take a snapshot of this picture, which beautifully encapsulates how to assess the risk for prophylaxis. Just like all of us now use the surgical safety checklist, and all of us who are working in integrated theaters, in our systems itself, the surgical safety checklist is there. So we have to take that, otherwise we can't proceed with the case. Similarly, I think the time has come that we have these scoring points. We can choose either the Rogers or the Caprini score. And it's very simple to score. So in the Rogers score, if it's a stomach or an intestine surgery or a hernia surgery, it gets 2 points. Cancer, chemotherapy, transfusions, all of that gets 2 points. If the patient is a female, that's the case in all gynec surgery, it gives us 1 point. So if the Rogers score is less than 7, then this patient is at low risk, but she still needs a mechanical prophylaxis. This is the point which I may want to really outline, that you may not give her thromboprophylaxis with heparin, or with rivaroxaban, but you should give a mechanical prophylaxis to all the patients who undergo a surgery, even if they are low risk. So if the Caprini score is 2 or 3, they still need a mechanical prophylaxis. Now, so this is the Rogers score in detail. If people are interested, you can take a picture of this. And this is the Caprini score. Now, if you see the Caprini score, a score of 1 is given to women who are more than 41, women who have unexplained or recurrent abortions, who have used oral contraceptive pills. So many of our patients who undergo elective surgeries or emergency surgeries will have 1 or 2 of these. So the mechanical prophylaxis, what we are practicing currently is the DVT pump, that is the IPC device. Compression stockings can be used, but most of the times intraoperatively, we end up using the DVT pump. Now, when it comes to the pharmacoprophylaxis, all of us know, we are all familiar with the use of low molecular weight heparin, and we are all very, very comfortable because we've used it in a lot of obstetric cases. Now, the good thing is that now we have factor 10A inhibitors, which are orally active. So the patient does not need to be injected. And so we have rivaroxaban. Unfortunately, there's not even a single trial of rivaroxaban as a prophylaxis in gynec surgeries. But most of the data from abdominal surgeries suggests that rivaroxaban is at least as effective as low molecular weight heparin, which has now become the standard of care for prophylaxis. So I think we're already running out of time. So we just need to understand that the novel anticoagulants, among which rivaroxaban is the one which we have for a long time. We also have direct thrombin inhibitors, that is dabigatran. Both of these, how to use it? Unfractionated heparin, we don't use it that much. Low molecular weight heparin, the dose is 40 milligrams subcutaneously. If the patient is heavier, we can use 40 milligram twice a day also. But in renal failure, the dose adjustments have to be made. The patients with renal failure, we also have to be cautious with rivaroxaban, but luckily most of our patients will have normal renal function. So when it comes to the ACOG guideline, although this is a very dated guideline, it was published in 2007, but Caprini score of 1 or 2 needs no prophylaxis. If the Caprini score is even 3, then also the patient needs the mechanical prophylaxis with IPC. So all of our theaters, just like now, we never operate without a ETCO2 monitor. We never operate without a remote controlled table. Similarly, none of us should be operating without a DVT pump in our post-operative areas. So the ACCP recommendation for prophylaxis is like this. So most of the time they are recommending the low molecular weight heparin. But what if the patient already has a thromboembolism or a DVT? In that case, we have to give the therapeutic dose of anticoagulants, and the therapeutic dose is like this. The first thing to do is to check the renal function. If the renal function is normal, you can give either low molecular weight heparin or you can give the oral anticoagulants. In case the renal function is abnormal, then oral anticoagulants, that is factor 10 inhibitors, are out, and you can give the therapeutic dose of low molecular weight heparin. The only thing that we are worried about when we give therapeutic dose is the occurrence of bleeding. But most of the times, DVT will occur later than the surgery has happened. So it will happen on the 3rd or 4th day. So by that time, most of us are sure that the patient is not going to land up in bleeding. So that is not a concern when it comes to the therapeutic anticoagulation. So to summarize, in all our laparoscopic operative surgeries done in obese women, we have to have a scoring system. This scoring system should be there in our case files. And any patient who has a point more than 2 should always get a mechanical prophylaxis. Others should get a pharmacologic prophylaxis. Always make sure that the patient is hydrating and is ambulating early. We advise early ambulation, but sometimes, especially in the villages, the psychology is such that even though they feel fine, they keep resting. They don't move much because everybody tells them that they have to rest after a surgery. And pneumoperitoneum should be less than 12, or operating pressure should be around 12 when you operate. We need actually more trials with more and more adaptation of laparoscopic surgery. And I think Iage should come up with a guideline of our own when it comes to the thromboprophylaxis and treatment. So thank you so much, Mala. I would be very glad to take any questions if at all.
Yeah, thank you so much, Dr. Priya Bhave. That was an excellent presentation. In fact, it was very, very informative and useful because these topics generally we don't touch upon, apart from your regular surgical topics, these kind of topics are generally ignored and we kind of take the help of the vascular surgeon when we end up in a situation like this. But it is really very, very crystal clear from what you have depicted beautifully. So, because most important thing what we have to understand is like though that you have showed beautifully the study between the open surgery and laparoscopic surgery, where the incidence of DVT is more with open than in laparoscopy, but then a laparoscopy has its inherent risk because of the certain technicalities which we do, like the deep Strendelberg position and the increased intra-abdominal pressure, which causes so much of venous stasis. So that per se itself, it's indicator for the risk for DVT. So that is a reason where we have to be careful even in laparoscopic surgery, unlike open surgery as well. And the risk scoring system which you have showed is really wonderful. I'm sure it is going to be very useful for all of them who really watch this program. And of course, what was really highlighted was that how we are going to really manage all these patients. The most important thing is, as you said, we are not going to overtreat, and at the same time, we are also not going to undertreat. The most important thing is we have to make sure it is a case of DVT, and diagnosis is the most important thing. What is your call on doing a D-dimer test for these patients post-operatively to make sure that they're really having a DVT or not? So what do
Yeah,
you
so the algorithm shows us that if the score is more than 2, then and ultrasound is not available within 4 hours, then you send a D-dimer. But most of us work in hospitals where we immediately get a Doppler. So practically, even in obstetric patients, wherever we suspect a DVT, we don't do D-dimer. And gynec surgeries also, although we get less cases, we directly send for a Doppler and check.
Okay. So only thing is,
So
I think
what?
we have to be very cautious when you're doing malignant cases, oncological cases, because especially in case of, they say the mucinous producing ovarian tumor, they have more high risk for a DVT compared to any other tumor. So in such cases, I think we have to be extra cautious and make sure that, they do not end up with DVT. So it was an excellent presentation and thank you.
Dr.
Yeah, please go on now.
Priya, I would like to ask you, what is the time duration afterwards you give low molecular heparin as a preventive measure? Surgery time?
So we will restart it around 24 hours after the surgery.
Okay.
So we
No,
start it after surgery, 24 hours after the surgery for a hysterectomy.
Okay, for all hysterectomies you are giving as a preventive
After
measure?
24 hours, if at all we give, if the test scoring is high and she requires a pharmacologic prophylaxis, then we give low molecular weight heparin, but we give it after 24 hours of the surgery.
We started
Okay.
at 12 hours.
Can I tell something, Kalyan sir?
Yes, please. Yeah.
Hello.
Yes,
Sir,
Prabha.
usually I give after 4 hours of my surgery, because most of the people say usually it is better to means most of the things better to give with up to within 6 hours post surgical. Hello.
Dr. Priya, what is your say about this? Yeah.
So that is debatable. So there's another risk scoring which tells us about the risk of hemorrhage after initiation of anticoagulants. So you can decide it depending on the type of surgery. How much is the risk of hemorrhage? Now, most of the times in hysterectomy, there's no risk of hemorrhage. But I had a patient who was on anticoagulants because of a valve replacement. And the cardiologist started her heparin in the evening. And at night, she had a lot of hemoperitoneum. We had to reopen. So we have changed our policy and we put a drain for all of them and we started only at 24 hours.
Okay, thank you. Dr. Tamilarun, can you just conclude the session, please?
Dr. Tamil?
Yes.
Can you, yeah. Please unmute yourself. Dr. Tamil, please unmute yourself.
Yes, ma'am.
You need to close your device, second device.
Yes.
Yes, Dr. Tamil.
Yeah, go ahead, Tamil.
Yeah, this was an excellent and spectacular performance. The meeting, though it's almost nearing 9:30, the New Year Eve, I can see the dynamic in all the surgeons. I thank Malaraj ma'am once again, who's my teacher. I really admire her a lot. And I don't have any practical experience. This is my first webinar in the IAGE to be part of a chairperson. Thanks a lot for the IAGE team. Looking forward to the future meets. And the videos are excellent by all the surgeons. And all this thanks to Dr. Kalyan sir, Dr. Pandit sir. And this was a nice, you actually New Year a treat for the IAGE members all. Thank you, sir.
Yeah, thank you, Dr. Tamal. We wanted some you also in the team. So,
Yeah, ma'am.
Dr. Tamal, yeah, thank you so much. So now over to Dr. the Kalyan Vamade, our secretary, for the vote of thanks.
Thank you, Dr. Mala, for this wonderful webinar. Today we had so many stalwarts talking about the complications in laparoscopy, starting from anesthesia to bowel, bladder, ureter, and all other complications, including the DVT. I thank Dr. Pandit Palaskar, President of Iage, and all Iage team members. And particularly, I'm so happy for that Dr. Malaraj conducted this webinar as MOC as well as MCM member Iage, and really congratulate Dr. Malaraj for being a convener of this webinar. I'm thankful to the all chairpersons and speakers, that is Dr. Niranjan, Dr. Madhubala, Dr. Rishikesh, respected PG Paul sir, respected Hafiz Rahman sir, respected Dr. Sanjay Patel sir, and my friend Dr. Priya Bhave for their respective talks. And I'm thankful to all chairpersons, that is Dr. Ashwini, Dr. Padma, Dr. Renu, Dr. Prabha, Dr. Dinesh, and Dr. Aruna Madam, and Dr. Tamilarasi Arun Kumar for all this wonderful discussion about this webinar. I thank Team Corona for this wonderful webinar. They have been our academic partner for this webinar. And as everybody knows, IAG is conducting webinar every month on different topics. The next and last webinar will be on the last week of January. So I thank everybody for having an interactive session on complications in pregnancy. Thank you, Dr. Pandit sir and Corona team for having this webinar. Also, I'm really thankful to all the IAG MCM members and all the members who have attended this webinar. Our count of delegates today is around 1,000, and most of them are from India, and around 40 delegates were registered from abroad also. So I really congratulate Dr. Malaraj for this wonderful webinar. Over to Dr. Pandit sir.
Heartiest congratulations, Mala, for being a convener.
Can you just stop sharing, Mala? Screen?
Yeah.
Very nicely conducted program, and we are very thankful to all the stalwart speakers, chairpersons, and the sponsors for.
It's too early.
Sorry.
Thank you so much. You can
Yes,
go
Dr.
ahead with
Pandit,
this.
No, sir.
We'll finish with the Janaganamana. Yes. Dr. Pandit sir, you continue, sir.
So once again, congratulations, Mala, for a wonderful organization of this webinar, which was very informative and very well appreciated by all the delegates. We are very thankful to all our stalwart faculty, chairpersons, and dynamic secretary, Dr. Kalyan, for being here. So thank you, everybody. IAG is proud of all of you. Thank you.
So thank you so much, sir. President IAGA, Dr. Pandit Palaskar, sir, Secretary IAG, Dr. Kalyan Bamade, and the entire team of IAG for giving me this opportunity to organize and conduct this webinar. A very interesting one and informative one is what, and we had such eminent faculty in our team, and I would like to extend my heartfelt thanks to all our faculty who had accepted our invitation immediately and made sure the entire presentation was done done with full justice. And I'm sure all the members who attended today's program would have definitely benefited out of this webinar, because it is one of the most important topic which any endoscopic surgeon would like to really know, and because it becomes handy in times of need. And I thank IAGE for giving me this opportunity, and also Corona team for being an academic partner and helping us to have a very seamless transmission of the entire program. Thank you so much, all the faculty. And also, last but not the least, I would like to thank all the delegates. We had more than 1,000+ delegates who had really keenly watched the entire program, and the entire program has been successful only because of the delegates like you all. And thank you so much. Let us continue our learning and keep learning and continue keep progressing in our endoscopic surgeries. Thank you so much.
Thank you. Can you just stop recording, please?